Good afternoon and welcome to the Committee on Hospitals. At this time, we ask if you can please place phones on vibrate or silent mode. Thank you for your cooperation. Chair, we are ready to begin.
And sorry, I'm gonna reach you back because I did not put the mic on for those online. Good afternoon, my name is Mercedes Narcisse, and I'm the chair on the Committee on Hospitals. H&H fiscal 2024 budget totaled $9.3 billion, of which $913 million is funding from the city to cover services such as Be Heard program, NYC Care, Public Health Corps, and other vital services. H&H projects a loss of $144 million in fiscal 2023 and $110 million in fiscal 2024 due to higher than anticipated expenses on temporary nurse staffing to keep our facilities running and delays in federal and state revenues. New York City and H&H are both at a pivotal moment in our city's history, recovering from a global pandemic and now managing a crisis of asylum seekers, making New York City their home. This committee has many questions on the fiscal status of the system, both in the short and long term. The delays in funding from federal and state sources, H&H work on the asylum seekers citywide operation and staffing needs system-wide. Sorry. We want to make sure that the city continues to provide adequate services as it moves to a new phase in COVID services, while continuing to expand the vital services under primary care and behavioral health care that H&H provide. At today's hearing, we will examine several changes to H&H budget and review the $913 million in fiscal 2024 to support the city-funded services like NYC Care, Public Health Corp, and correctional health services, and how they will affect all New Yorkers, ensuring that H&H adequately funded and staffed is a priority of the council. So we look forward to discussing how the state and the federal supporting our public system, hospital system. I want to thank Dr. Katz, as usual. You know I care about Dr. Katz and H&H team for being here today to testify. And I look forward to learning more about H&H plans to ensure that H&H can financially continue providing the services to New Yorkers, including those that seeking the asylum seekers that we talk about, to support the efforts of going forward. In closing, I'd like to thank the committee staff, Assistant Director Grillian Francisco, and Policy Analyst Manoa Butt for their work in this hearing, as well as my Chief of Staff, Syed Joseph, and all my other staff that contributed. I will now turn to the committee counsel to administer the oath.
Thank you, Chair. Is it working?
Yeah.
Okay. I will now turn over to, sorry. Thank you, Chair. We will now hear testimony from the members of the administration. Will you please raise your right hand? Thank you. Do you affirm to tell the truth, the whole truth, and nothing but the truth before this committee, and to respond honestly to the council member questions?
I do.
Thank you. You may begin.
Good afternoon. And Councilmember Gutierrez, so nice to see you. I think it's so great that the committee is headed by a registered nurse who actually understands hospitals and has worked in hospitals and know how critical health and hospitals role is in this city. I'm Dr. Mitch Katz. I'm a primary care doctor, and I'm president and CEO of Health and Hospitals. I'm here with my Chief Financial Officer John Olberg, and with Dr. Patsy Yang, who's in charge of our correctional health services. Happy to report on our finances for fiscal year 2024. We are a large system, the largest one municipal system in the country. Every day, our 40,000 employees live our mission of providing high-quality health care services with compassion, dignity, and respect to all, regardless of income, gender identity, race, sexual preference, or immigration status. This committee knows the devastating impact that COVID had when it arrived 3 years ago. It's required a huge commitment of our energy and resources. We've put everything into it ourselves. Our staff put their lives on the line. We put whatever dollars we had, whatever energy we had to get New York City through. And I'm proud that while COVID has not gone away, I very much feel that we have reached a point where we have shepherded the city safely through the worst of COVID. How did we do that? We did 14.5 million tests. It's an extraordinary number. 14.5 million tests for COVID were done by health and hospitals. Our mobile test to treat program has administered 4,700 Paxlovid prescriptions, and our virtual express care has connected people with prescriptions 37,000 times. Keep in mind that New York State, when they wanted to make Paxlovid available, chose New York City's Health and Hospital as the group to do that. And also, we have our aftercare program for long COVID, which has proactively reached out to 500,000 New Yorkers and referred 57,000 people to critical care. As we shift into making it part of our standard of care, we will still maintain our 212 COVID-19 number so that people can call us when they want COVID care. The chair has referred to the HERCs, and I'm very proud that we've provided care to over 9,000 asylum seekers. This was not originally a health and hospital project, but we responded to the heroic efforts of our sister departments, the Department of Homeless Services, the Department of Immigration Services. When they reached the number of asylum seekers was so large that they no longer had capacity, we swung into action to help them out. We've connected 400 patients who are homeless to housing. We administered 15,000 Mpox vaccinations. We've expanded our Be Heard program. Our show vans are on the street, reaching out to homeless individuals and providing buprenorphine treatment for people with opioid use disorders. We've expanded our lifestyle medicine service to all of our 11 hospitals and offer plant-based lunches and dinners as the default choice. We test wastewater for infectious diseases at all our hospitals. We grew to over 426,000 unique primary care patients. Our ACO earned savings, and we continue to make major investments into our state-of-the-art lab at Bellevue, our extended care unit at Kings County, and the first cardiac rehab center within our system. Our health plan grew to over 700,000 members. All of our hospitals received baby-friendly designation. Kings County and South Brooklyn received the prestigious Pathway to Excellence Award, and our Elmhurst and South Brooklyn received the Beacon Award for Nursing Excellence. In terms of the specific financial performance, the chair already mentioned the challenge of hiring sufficient staff due to the nursing shortage. And so we've had to rely on the use of temporary nurse staffing, which is not something we want to do. I want every nurse in health and hospitals to be our permanent nurse and to have that as their lifetime commitment. but at the same time, I have to keep my trauma centers open and I have to maintain safe ratios. And so the cost of maintaining sufficient nursing has put us in a negative net balance. So we are currently anticipating a loss of $144 million in fiscal year 2023, which is about 1%, due in part to delay in the receipt of certain federal revenues, because remember, we're operating primarily under a cash basis. Our revenue improvements continue to be on track. You'll remember this was our strategy for getting out of our deficit. Instead of cutting hospitals the way some people thought we should, we said no, we could get out of this by growing, and we've continued to succeed at that. Through December, we've generated $397 million in revenue, have a projected line of sight of $676 million for the full year on target. We don't bill our patients exorbitant amounts. We only focus on billing our insurance companies. In terms of our closing cash, we're at approximately 26 days of cash on hand, which is $650 million. Our preliminary financial plan remains stable. We work closely with our city and state and federal champions to make sure that our position is one that is stable. We are advocating aggressively for equitable access to state funding, and we've had great success with our champions in Albany, including State Senate Health Chair Gustavo Rivera and Assembly Health Chair Amy Paulin, plus so many of the state senators and assembly members who have been supporting us. I know that city council members, that all of you have also been using your networks to make sure that the state and federal government understands how important health and hospitals is. There is still a dish cut on the federal level, which would be devastating for us, and we ask that you continue, as you have in the past, to advocate for us to prevent this dish cut from happening. So thank you so much for inviting me. Thank you for the privilege of being the president and CEO of this amazing health system. Thank you.
Thank you. I have to acknowledge my colleagues, CM Powers and Gutierrez. Thank you for being here, Dr. Katz. It's about getting to know how's our hospital running in New York City. First, I would like to start with Be Heard. Last fiscal, the council called for the Behavioral Health Emergency Assistance Response Division, or Be Heard program, to be funded at $55.3 million, which the administration included in the executive budget. However, there continues to be question regarding the expansion of the program and current operation that we need to understand. The November 2022 plan reduced the budget for Be Heard this year by $3.7 million from H&H budget for fiscal 2023, going from $18.3 million to $14.6 million. Be Heard is budgeted for $18.3 million next year. Can you explain why was Be Heard reduced and what was the impact of this reduction in services?
Thank you, Chair. The amount was reduced to reflect the actual staffing. Working as a Be Heard social worker, as I'm sure all of you can appreciate, is a very special job and takes a very special person who's prepared to be out in the field, who's prepared to be able to de-escalate a complicated situation. And with the shortages in general of mental health professionals, we haven't been able to identify as many qualified people as we would like. Each Be Heard team includes 2 EMT paramedics and a mental health professional. So the funding reflects the actual current use, so we will not be decreasing. I really think that as people see how useful a job this is and what a meaningful difference they can make, we will have a large group of alumni and current workers who will encourage others to apply. We are hiring as quickly as we possibly can to fill all of the slots.
Thank you. Given that the city has reduced funding for the program 2 years in a row, are we sure we are budgeting according to the program expansion?
Well, again, I wish that we were able to hire faster, although it's not a hiring problem, it's an identifying people who are right for this work and who want to do it and have the heart for this kind of work. So I think that in general it has been getting easier as people know more about it, and we will be able to meet the current targets.
Thank you. Was a reduction in PSO OTPS is related to staffing shortages for social workers?
Correct.
Thank you. How many staff do you currently have this year for Be Heard, and how many new staff do you plan to hire?
I'm sorry, give me 1 second. I don't know that number off the top of my head.
Yeah.
I don't think we have.
Yeah, I don't think we have that number.
I think the closest I can give is Be Heard currently operates 7 days a week, 16 hours a day, and so in 15 precincts. So we're talking about 3-person teams that are operating 16 hours a day in 15 precincts. But we'll have to get you the exact number.
Okay, we'll get back to that. How many staff do you currently have this year, and how many new staff do you plan to hire?
I'm sorry, I'll have to provide that number to you after the meeting. I don't have the exact number of staff we currently have.
Thank you. Can you walk us through how the $18.3 million in fiscal 2024 is sufficient to provide the level of services needed?
Sure. So the 18 million provides the current level of support as we estimate on terms of how many staff members we'll have. We've had very great support from the City Hall, from the City Council, and from OMB on this program. If we were able to identify additional staff members, I'm sure they would be happy to provide us the funding to continue hiring. But this is based on what we believe we'll be able to hire in fiscal year 2024.
Okay. What challenges have there been with staffing and training members in the program?
It's a very non-traditional job. And again, I think it's a job that for some people is a lifetime calling, and they can see what a difference it makes. But this is not a traditional job. This is out in the field. It's dealing with people who are in crisis. It's 7 days a week, right, which can be difficult for people who have responsibilities for small children or taking care of parents, so that it's not a Monday through Friday 9 to 5 job, and it's certainly not a job that anybody can do on Zoom.
Thank you. This past summer, the data showed that under Be Heard, the percentage of subjects assisted by Be Heard that got transported to the emergency room, which is the ERs where I used to work, instead of diversion centers actually increased from 45% to 59%. As of today, what is the percentage of individuals that goes in the ER versus diversion centers?
I don't have today's numbers, although we publicly report all of the data on the OCMH website. And we're working on a robust evaluation of the Be Heard. Because where people go can reflect what their level of acuity is. And we've certainly seen with the growth of fentanyl, the number of very severely impaired people is growing in New York City, and may require more people being able to go to an emergency room in order to be able to be handled. So, you know, our goal is to keep people out of jail and to get them the care that they need. And those are the two things that matter the most to us.
Got it, thank you. How is the Be Heard program being evaluated? Is the city's health department of H&H evaluating the program?
We're looking for an external evaluation. We think that would be the most valid.
Okay. Have you considered adding indicators for Be Heard in the mayor's management report?
We would be completely open to adding them if the management group will accept our putting them in.
Okay. Now, okay, funding for evaluation. Is it in the budget? I didn't ask that one, so.
We could certainly make it available.
Yeah, I think that the amount for the evaluation is such that we would make it available.
I usually give 5. Thank you. 5 minutes. Okay, we're gonna go to staffing. What steps have been taken to improve H&H nurses ratio?
Well, boy, you as a nurse know how challenging this is, and I just want to say that what nurses went through during the COVID pandemic, what heroes they were and how taxing it was. And it's not surprising that a number of nurses felt exhausted, retired early, decided they wanted to do a reduced caseload, and the fact that our compensation and benefits has lagged behind the private systems has, you know, also caused us a problem. We have gotten much better at hiring. Besides using a dedicated web page and social media, we have on-spot interviews where we have all the people, all the hiring managers in one room, and it's a little bit like speed dating. People come, they find where they want to work, they meet the manager, they leave with a job offer. We no longer have those difficult periods of time where people put in, you know, I think when I came, a very long application and waited to hear. It doesn't work that way at all now. We have these group interviews and hire people as quickly as we can. We have a loan forgiveness program, which I think has been very effective, especially at recruiting nurses who are from the same communities as our patients. We have a nurse residency program in order to keep our new nurses. But it is a challenge, and we are hoping that through our negotiation with NISNA, we have a contract that enables us to keep our nurses. We want to pay fair wages, and we want to have wages that enable us to hire and retain our nurses.
Thank you. Does H&H have plans? Now, what you're saying, it seems like you have plans to reduce the number of temporary workers. You have plans to
I'd like to
reduce
reduce it to 0. Right, I mean, really, in my view, you hire temporary positions because somebody is on maternity or paternity leave, or someone has a short-term disability need, but not for long-term periods of time. But again, that requires having a full-time group of nurses, and that requires paying wages that are comparable to those that nurses can earn in the private sector in New York City.
How much do you anticipate to spend on temporary staff in fiscal year of 2024?
We don't have, in 2023, the figure is how much, John?
Yeah, we, on temporary staff, as we had mentioned, Dr. Katz had mentioned in the testimony, one of the big reasons why we're overexpending on the budget is because of temporary staffing. And, you know, the models that we develop and the analysis that we've done thus far is that's driving about $150 million of our shortfall, you know, for the period. We can get you the total value of temp contract costs. That's no problem. We could provide that information to you. But
Okay, for 2020.
Going forward, we want to drive it to zero.
yes,
Okay,
The
for
goal is to drive it
2023.
to zero.
yep.
So you're gonna send me the course for 2023?
Yes.
And 2024, what's the plan?
2024, as Dr. Katz said, right? Our goal is to always drive that down to close as zero as we possibly can. We very much appreciate our own nurses, you know, working in our hospitals. It provides better care, as you know. So that's our goal.
But approximately, you don't have the ends roughly of how much we spend in 2023?
No, I don't, but we could provide that information to you.
Yeah. Barron's, okay. Now, we'd like to acknowledge my colleagues, CM Barron, CM Wrestler, and CM Joseph. Thank you. How many agency and traveler nurses are currently working in the New York City H&H system in general?
Too many.
I think the number is
it's
roughly 2,000.
2,000.
Could you break it down by provider type? How many are in the 11 acute care hospitals, in the long-term care facilities, and in the clinics?
No,
Yeah, I mean, predominantly, right, most of these nurses are in our inpatient facilities.
it's overwhelmingly hospital. It isn't the other two sites.
Not acute care?
No, it's all acute care. That's where that's the hardest areas to recruit nurses right now is ICU.
Oh, in the, okay.
ICU, emergency room, surgical nurses. Those are the nurses we are able still to recruit nurses for the nursing home and outpatient nurses. But the emergency room nurses, surgical nurses, ICU nurses, very hard for us to recruit.
Really? I used to be a year a nurse, so I have to find out. Can you give us, down the unit in each of the facility in New York City, the number of agency nurses currently working? How does this compare to New York City H&H RN headcount?
Right, if I understand the question, I think it's 2,000 is the number of, you know, temporary nurses out of a total of about 8,000. I think what Dr. Katz also had mentioned is how committed we are to the nurse staffing ratios. You know, from a budgetary perspective, we try to make sure that there's enough resources at the bedside, and we fully appreciate, you know, the value of the ratios. So to ensure that we do have the resources at the bedside, you know, we have gone forward and hired, you know, temporary nurses. We've been very busy at our facilities, in particular, you know, the EDs have been, you know, very busy over the past couple of months. But again, our goal is to hire our own nurses in the future and spend our resources on our own staff.
There is also some hope that things will be better just because of the epidemiology of the situation. I mean, the last period was the triple pandemic of COVID, flu, and RSV. And we've had census. For example, Bellevue is currently running a census 200 patients higher than pre-COVID. So it's both been difficulty in workforce, but also just that the workforce had to grow in order to deal with a much larger census. We have seen over the last few weeks as the COVID numbers have improved, the RSV numbers have improved, and the flu numbers have improved, that we're not as crowded. And when we're not as crowded, we don't have to rely as much on the temporary nurses.
Can you provide the current RN headcount by facilities?
Yeah, it's overall 8,000, but we'll have to give it to you by facility.
Yes.
8,000, but not quite?
8,000 is the total.
Okay. How has this number changed throughout the pandemic? You just mentioned that it changed, but for hospitals, by facilities.
Yeah, we'd have to get it to you by hospital.
Okay. Can you tell us what agency and traveler nurse utilization was prior to 2020 and how that number changed over the past 4 years?
John will see if he has any
Yeah.
exact, but I can tell you, in general, it's just huge compared to 2020. We relied much less on temporary nurses because our census was much smaller and we hadn't lost the large number of nurses that we lost who left the profession after COVID or who left for higher salaries elsewhere. So it used to be very low, and we want to get back to that. We want our own nurses.
Yeah, for modeling purposes, we usually assume about 5% of the nurses would be contract nurses at a maximum. But we could provide the information, pre-COVID.
Thank you. Can you tell us the average rate billed to H&H for agency traveling nurses? And how much do these nurses cost per hour per year?
Yeah, the amount per hour is ranged tremendously, right, during our experience.
Tremendously, how much?
Yeah, tremendously. With our experience with COVID, we renegotiate, those rates frequently, depending on, the needs. It's a market, in essence.
Give me a number.
Today's is about $110 an hour. But that number will change next week. I'll just be clear. It fluctuates quite a bit, and that's what we've been struggling with from our financial plans perspective.
So that's why the 110 per hour is what the agency.
Correct. That's what they charge us.
And sometimes it varies by the type of nurse too, just
The years of experience?
years of
What is it?
experience or the type of nurse. ED nurses tend to cost us a little bit more because the market is in greater demand for ED nurses at the moment. So again, it fluctuates, 110, 130, yeah.
So how much regular the one that's working in the hospital right now, they getting per hour?
Today, it probably averages around 110. We could provide that
No,
information.
she's asking for a regular
The
staff.
regular nurse, not this
Our
traveling
regular
one.
nurse per hour is probably about $70 to $80 an hour.
So you know how that feel, right? Between the nurses that working, that's where I have a lot of complaint coming to me as a nurse, and they're holding me accountable on that one.
Yes. As the CFO, I also experienced that same feeling.
For each year of the pandemic, could you provide us a detailed turnover rate by facility and unit for registered nurses?
We'll provide it.
You don't have it, okay.
No.
Has turnover at H&H increased or decreased during the pandemic?
Increased substantially, and but that's the same as all the health systems are reporting. That's a common phenomenon, and you can, as a nurse who lived through that, you can understand why.
What is the current cost to H&H, which I asked you, for the training? If you have to train a registered nurse that just come to you, how much approximately it costs you?
Well, the way I think about it is how long does the training take? And in general, I'd say the training takes about 6 months. So it's basically costing you a half year of their salary to train a nurse. And that's why in previous years before COVID, one of the first things we did was negotiate a retention bonus to hold people at 4 and 5 years. And OMB was very helpful. John did an analysis that showed that we were losing money because we were taking nurses, we were training them. During the training time, we're paying for the training. They're not working yet. Then they would leave us with 2 years' experience, and we'd have to repeat this whole cycle. John did a detailed analysis showing that that was a money-losing effort, and OMB helped us out and gave retention bonuses for nurses to stay on, especially in those early years before the city pension begins to kick in. You can't, a nurse 3 years out of school is not interested in the city pension. He or she is thinking about, how am I going to pay my rent?
You got that right. You got that right. Now, I want to get somewhere. I heard something, OMB, and would you agree that the city's healthcare workers have placed their lives on the line, providing so much care for us during this pandemic, and they are still our frontline workers, right? Wouldn't you care for their well-being?
Absolutely.
Okay. Given the current strain of the healthcare system, would you agree that we need to address retention and equipment
Absolutely.
and attribution to all the things that they're doing, right?
Yes.
Let's say, for argument's sake, if a head of the hospital or the ER or HR person have to retired, how you go proceed to hire the next person?
So depending upon whether it's a position with a list or it's a managerial non-list, we would do an open recruitment and hire if there's no list.
Do you have to communicate with anyone else if you have to hire the head of a hospital?
No.
You don't have no one to speak to. You just hire the person? Because from the last hearing, I heard a question, and I heard that the answer was the OMB have to approve the process. Is that correct?
Not for health and hospitals, because remember, we were created in separate legislation as a state agency, so our hiring
So
is
your
not-
hiring has nothing.
not controlled by OMB. Of course, we require and depend on OMB to help us with the subsidy that enables us to run. But no, our positions, we're not under vacancy control by OMB.
Not at all.
Also, most of our money comes from revenue that we generate.
Okay.
Right, and so often, if I don't fill a position, I actually lose money. Because I can't, especially in healthcare, and you remember this from your work, healthcare is a team effort. So
Okay.
if I have the surgeon, the anesthesiologist, the first nurse, but no circulating nurse, there's no surgery. And then I'm paying 3 people, but I got no revenue. So I think OMB understands that and allows us to hire appropriately.
Thank you. You know, I appreciate folks that caring for the city, and especially in addressing the inequities. But in order to do so, we need to have nurses that love the city, that stay in the city. And I heard you say that, and I'm going to hold you accountable for that, because that's what we want to see more of, the nurses to stay home and work and feel like they're not being disrespected. And that's what I'm hearing. And it's just saddened me by nurses, the people, the backbone of healthcare system in our city is saying that they feel like disrespected, like they feel like it's a slap in their face for them not having the financial support. Because yes, they love the work, but financially they have to be able to pay the bill. You just said it yourself. So I'm gonna call on some of my colleagues, because I give them, because they want to ask some question. CM Gutierrez, please. Oh, CM Powers at first. Oh, you yield to her. So now make up your mind. Yeah. Hola, Council Member
Okay,
Brooks
thank
Powers.
you, and thank you, Dr. Katz, for your testimony, the work that you have been doing, continue doing, especially in my district, in the 31st Council District. We appreciate you deeply for that.
Thank you.
So in line with some of the questioning of the chair, I had some similar ones, especially in terms of our nurses who, you know, I always say we beat the pans at 7 p.m. every evening for them. And right now, you know, we're failing them in terms of making sure they're able to afford a quality life. So a piece in the Daily News this morning said that there was high turnover and the hiring of the so-called traveling nurses at Jacobi Medical Center is likely costing the city tens of millions of dollars a year in additional costs. On average, these nurses make 2 to 3 times on average than nurses on staff permanently. And I'm hearing this in my district at St. John's as well, that it's a big difference in terms of what the agency nurses are being paid versus the staff nurses. So I think this is across the industry right now. Does Health and Hospital believe these figures are accurate? And how does Health and Hospital plan to address these concerns at Jacobi Medical and elsewhere?
Sure. Well, thank you, council member, and it's an honor to work with you in your district. As we've all agreed, the goal should be us hiring permanent nurses. The nurses who work under registry do get paid more, although they do not get the 110.
Right.
That's I mean, one of the things that most bothers me is actually there's a middle person getting a large cut of the money. Right, this is the way the market works, right? So the registry company is taking a portion of the money which is not seen by any nurse, right? But even if you factored that in, it is true that the agency nurses are earning more, not just at Jacobi. We're very clear, it's all of our acute care hospitals. And the solution is that we need to have payments to our nurses that is fair and equitable, especially compared to the market in New York City. The reality is that being a nurse is a noble profession, whether you're working for us or you're working for another safety net provider or another hospital. And so it's understandable that a nurse might say, well, but I could earn $20 more an hour over there and then leave us. And so even though people love our mission and the fact that we have the best mission in town, they're not going to stay with us if it's too large a difference in salary. And we're hoping in the new NISNA contract, I mean, this is, the good thing is we have a vehicle, all of us, to solve this, right? The city is in active negotiations with NISNA, and that's the vehicle to provide compensation that is fair for the nurses and that recognizes their amazing contribution to this city.
So Dr. Katz, I just have a few more questions, and I know the clock is running on me. So one, I would love to hear an update on the city's ongoing negotiations with NISNA, but also a few more questions I'm gonna just ask you so you could then answer them, if that's okay.
Sure.
So the council's report on the health and hospital budget is critical of Health and Hospital's 10-year capital plan, which front loads costs in the next few years. And per the Health and Hospital plan, projected spending in fiscal 25 is more than 6 times projected spending in fiscal 29. Why is Health and Hospital taking this approach? Also, currently there's no funding included in fiscal 2024 for Health and Hospital to continue operating HERCs. What is Health and Hospitals thinking about the long-term future of these sites? What would Health and Hospital need to continue their operation? I do want to ask about the Distress Hospital Fund. I'm especially interested in this and wanting to know how much of this account has Health and Hospital received and expects to receive from the state.
Okay. I'm going to do them quickly and then come back because of what you said about
Hold
time.
on, I have a few more.
Oh,
I'm
okay.
sorry.
I'm writing.
I'm sorry. I know.
That's okay.
PPE, well, preparedness. We saw what COVID did. We got caught on our heels. And recently, Health and Hospitals announced plans to downsize its COVID-19 testing. My district was one of the epicenters in that pandemic. I'm concerned and wanting to know how will this impact the preparedness of the system for another surge or a public health emergency? And then my last question is, how much does Health and Hospital anticipate to receive from the Capital Transformation Fund, and what impact may that have on the system's capital needs? And that's it.
Do you know the Capital Transfer Fund?
That's the state dollars for the capital
I'm sorry, I can't hear you.
The state funding, it's in the state budget, that capital transformation fund?
yes.
Yeah.
Okay, so you do that. We'll do them backwards.
Yeah, so on that one, there's $1 billion that's, proposed in the budget. We've been advocating in Albany that a carve-out of about $300 million should be set aside for safety net hospitals, of which Health and Hospitals would receive a portion of those funds. That has been our position in Albany, and again, they're actively negotiating the budget, and we hope that we're successful there and we'll receive a portion of that. Obviously, it would help us. Our capital needs are very significant in Health and Hospitals.
Okay.
On the testing, while it's true with the end of the emergency, we are decreasing our testing capabilities. More and more people are going for home testing, and home testing kits are available free from the federal government. People can request up to 5, and what we're trying to do is to make it part of medical care. So last Wednesday when I was in clinic, one of my patients had symptoms that could have been COVID. In one day, I would have, a year ago or even 2 months ago, I would have sent him down for testing, and instead I swabbed his nose. Right, so now we just keep the bottles and we do the tests. So I think what COVID testing will become is the same as any other testing we do, like a strep throat test. We won't have if you have a child with a strep throat, you don't go to a special center, you go to your pediatrician and they swab your child's throat. Preparedness, I think we're good. We have the 6-month supply of all of our PPE, so I'm not worried about that. The distressed hospital funds, I'm sad to say that I think we will get 0. That's how it stands right now. We don't see a line toward Health and Hospitals getting any dollars, although we're continuing to request it. Under HERC budget, we work closely with OMB. Our board is very clear because of the legislation that created Health and Hospitals that we're doing HERC not as Health and Hospitals, but as a 24-hour, 7-day-a-week agency that's good at operations. And so we're happy. We recognized when our sister departments were overwhelmed with the huge number of asylum seekers, we were happy to help out, and OMB reviews our budgets and approves our budgets, so it's a joint decision, and that will be true going forward, that they will fund us for our efforts. We've had no challenges for that. Whatever we agree on the budget together, and then the money flows. We don't take a subsidy from it. We just, whatever it costs is what it costs. Can you answer, John, the 10-year capital front load?
Yes, so our capital budget is roughly $4.7 billion, of which 3.9.
I'm sorry, I'm having a hard time hearing you.
Yeah, our
Mike, bring the mic
Just bring
closer.
the mic closer, yeah.
Is that better?
Not really. Is it on?
It's on the red buttons. I'll talk louder.
Okay.
How about that? Our total capital budget is about $4.7 billion. Of that amount, roughly $700 million is federal. The balance is city funded. We're happy to go through the details of the capital budget with you. There's many lines that comprise the budget. The reason why you see that difference in the flow of funding and why it's front-ended is basically based our estimate of when we're going to develop the project and spend the money. It changes, right, from year to year based on where we're at with a particular project, but that in general explains why you see the dollars flowing differently.
But is it because you're front loading it, like, is there a risk that this amount may
In this,
like be far off from what's being projected?
no, I don't think so. Usually, we're very accurate in terms of when we say we're gonna spend the dollars within a particular fiscal year, we in fact do spend the dollars, right? It's something that we work on, with OMB. And in fact, one of the small adjustments we made in the capital budget was to bring some of the dollars from the outer years into to more current years, because we think we can develop the projects more quickly.
Thank you, Madam Chair.
No problem. Next is CM Gutierrez.
Thank you, Chair. 5 minutes, perfect, yeah. Good afternoon, thank you so much. I don't know if I've said this before, but I am a fan of our public hospitals, so I'm really glad you're here.
Thank you.
And Chair Narcisse does a fantastic job. I just wanted to confirm on the Be Heard piece, and I just really want to uplift that Chair Narcisse came hard, started with the Be Heard questions, because I think we have administration that wants to support Be Heard, but I think that there's also a lot of questions that us as council members who are doing the work on the ground with our communities are seeing how it's not necessarily meeting the bar that our communities need for safety. So if you can just confirm, and I apologize if you said it already, do you have a sense of what the percentages of the calls that are still going to PD?
I don't have that number. We'd be happy to provide it. I would just say, again, we like you, we believe in this program. I think it's not surprising when you consider how novel it is, that it's taking the city some effort to get it to where we want it to be. And that's how I view it, is that I just want to make sure that every year it gets better, every year it's more staffed, every year we handle more calls. But I'm not surprised that it's challenging given the work and the mission of it.
Yeah, I think and it doesn't sound like you have that, but just wanting to get a sense of the idea is to reduce interactions with PD, because these are folks with, for example, mental health crises. We've confirmed PD is not equipped to respond to that. We just want to get the data to confirm how many of those calls are still, majority it sounds like, being rerouted to PD, and whether or not this is doing what it's intended to do.
Understood.
Okay, thank you. The next piece that I wanted to ask about was about the campaign coverage for all. I'm not sure if you're familiar with it, but it's a coalition of all stakeholders wanting to raise the bar about getting every single New Yorker insured. Right now, they're having a big fight in the state, and the council, I believe, does its part in covering, NYC Cares to ensure that every single New Yorker, independent of their immigration status, gets access to emergency care. What do you think is the responsibility? What responsibility do we have as a city to fund health insurance for every single New Yorker? And what impact does that have in providing better health outcomes? What impact does it have in continuing to serve the most vulnerable Black and Brown communities? And what impact do you think it would have in the service that is being provided in those hospitals? If you could just tell me where you land on that.
Well, I'm a big believer in single-payer system, and I wish New York State would have a single-payer system that would include everybody, including all people who are undocumented. I think that's the only way that you can really both cover everybody and decrease the administrative expenses, which provide very little value. All the time in my own practice, I see people, even people who have insurance, who I prescribe an asthma inhaler, and I ask them the next visit how the inhaler was, and they tell me under their insurance it was going to be $80 and they couldn't afford it. So even if you have insurance, the way the current system is set up, there's no guarantee that you're actually going to get what you need. Many people have large co-pays, people have unaffordable amounts of money. I think the only answer really is a single-payer system. We could still have multiple providers. That's not a problem, but we would all have a single benefit that we could all be sure that ourselves and our neighbors are getting all of the care that they deserve. I think you would see a major improvement. You'd see people getting cancer prevention care that they don't currently get. You would see them get medications that they may not get. Again, in New York City, because of this city council and because of the mayor, people on NYC Care sometimes have better access, in my experience, than some of the private insured patients who have exorbitant copays.
Yeah, and I'm sorry to interrupt you, but do
Yeah.
you have a sense of how many New Yorkers walk in through H&H uninsured?
Yeah, our uninsured rate, depending upon the practice, is about 20%.
20%.
Right.
Okay. And do you have a sense of how many of those folks identify as undocumented?
Overwhelmingly.
Overwhelmingly. Okay, fantastic. Can I just get 2 more questions in, Chair? I apologize. Thank you. My next question is regarding residents. It's something that is very important to me. My sister was a resident during the pandemic, and I'm sure you know there was an exorbitant amount of stress for every single hospital employee, nurses, administrative staff, and residents. They have some of the highest suicidal rates. And so my understanding in advocating for them is that, you know, they're regular New Yorkers that are also fighting for housing just like everyone else. And just like their nurses, residents are also fighting for pay parity. Can you speak to the increase that some of the H&H residents are not experiencing? For example, at Elmhurst Hospital, I know that they're fighting for an increase, and just having pay parity with some of the other residents from other hospitals like Bellevue, for example. Can you share a little bit about where the negotiations are there?
Sure. Well, especially with residents, they're probably our lowest paid workers on an hourly wage, because they're generally working 80 hours a week. So, you know, they are very low paid and they have a very stressful job, and we rely on them to take care of our patients. So we are in negotiations now with CIR that represents our residents. And as with NISNA, you know, I hope that the result is that we come up with contracts that are fair. I am not out to try to get the lowest amount ever. I'm out to provide people a fair wage. I know what it's like to live in New York City and what the stresses people have in terms of getting apartments. I understand even city council members have trouble finding apartments in New York City. Right.
That's real.
Yes. Yeah, I saw the keys finally.
He's fine. No, it's
Yes.
real. It's real.
Yes. So they need to get a wage that is equitable. And yes, it's true that the other residency programs are generally paying their residents more.
Yeah.
But as with the
It's a
nurses,
challenge to keep residents in some of these public hospitals for that reason. In the same way that it's a challenge to keep nurses.
Absolutely.
It's a very similar campaign. So I just wanted to make sure you are supportive. And I was also born at Elmhurst Hospital, so show those residents and those nurses some love. That's right. We've debated whether or not there was overlap. And then my last question, thank you, Chair. And I know Chair Narcisse has been asking all the nurse questions about pay parity, so that's why I'm not asking about those specifically. Yeah, I'm very curious. My 2 last questions, answer them however you want, is about language access. We had a very, very comprehensive joint hearing last year with your committee and the Women's Committee about language access, and how crummy the existing language access resource is, which I think is just Language Line. We had a ton of people testify about connectivity, about that, you know, the infrastructure is really poor depending on where some nurses or where some residents are in their buildings. They have to use their own cell phones to interpret just because of the actual equipment is really poor. So I'm curious if you can speak to what kind of budget we have for language access, what kind of budget, what can we expect as far as improvement, and then the last piece is about the nurse retention. I know you alluded to that, Chair Nurse. I don't know if it was a comprehensive enough response, but I don't think that we're doing enough. We're not doing enough to keep the nurses here. We certainly don't demonstrate that by paying them enough. We don't demonstrate that but by taking years and years to achieve pay parity for them. So it's a concern that we say that we want to keep them here, but we don't respond to that need with respectful wages, with respectful staffing to patient ratios, with, you know, options for housing in a lot of these instances. So I'm just curious if you can get into a little bit more detail about what H&H is doing to retain nurses in our facilities. Thank you.
I'll start on the first. We spend $10 million annually on our language capability. And I will say, as a primary care doctor, I speak Spanish, but I need the translator for my Mandarin-speaking patients, my Cantonese-speaking patients. I have a Tibetan-speaking patient, I have Bengali-speaking patients, and I have a patient who speaks American Sign Language. And I'm able now granted, and I'll get to where I think the problem is, from my desk, I have no problem. I can always get it on the phone, and I can also do a video visit in person, and the ASL is on a video and works quite well. It's as if the person's in our room. I see the interpreter sees my patient. I think where we have some problems, it's as much an engineering problem. In some of our facilities, remembering the age, we don't have high enough powered Wi-Fi in all of our places to be able to get the phone or the video capability, and we're trying to fix that for a variety of reasons. It's not just translation, but also because we want to be able to do patient care monitoring remotely, so that if a patient is down the hall, we want the nurse to be able to see the heart rhythm. And we're upgrading all of our buildings. But in general, compared to any other system I've worked in, I feel like the language capability is quite good. Never perfect.
You'll hear from some folks later today that disagree.
Never perfect, but I understand. The other issue, there is more to do with nurse retention, but so much right now is the salary differential. And the fact that there are alternatives, right? If you want to be a firefighter in New York City, you're going to want to be one of the brave New York Fire Department people. If you want to be a nurse and take great care of patients, there are a number of options that you have. And so if our salaries are $20,000 less and people are trying to raise 2 kids in New York City, it's not surprising that after they get their training with us, they go off somewhere else. So I think you can always do better, and money is not the only factor that keeps people in their job. People stay because of camaraderie with their coworkers, they stay because they have a great boss, they stay because of a mission. But when the differential gets too large, it becomes very hard to hold on to people, and I think that's where we are now.
Thank you. Before I turn it over to my colleagues, I want to do a follow-up question with the language access, because I have some hospital that are telling me they don't have the budget. And I was shocked because one of them located in a place where mostly Haitians speaking Creole speakers, and they do not have staffing to support that. So to me, if you're delivering care, it's kind of hard for me, you don't have folks that can communicate in their language.
I will look into that issue.
Yeah, and if you say one-to-one, is one of in the middle of Brooklyn.
All right.
And you know which one, Kings County.
I think I have a good idea of which one that is.
Okay, so what is the cost difference of providing in-person translation compared to tele-translation?
Well, the big advantage of translation is the efficiency that you use it when you use it, right? So you pay by the minute because lots of people are calling into the same line. So, they let's say they have a Bengali interpreter who's working an 8-hour shift for the translation company, but multiple hospitals are calling that Bengali translator. When you have a person, right, then that person depends upon whether you need the Bengali translator at that moment. And often you have moments when you don't need the Bengali translator and other moments when you need 2 Bengali translators because you have 2 people who speak Bengali in different rooms. And so the efficiency has always been for the phone line because you can get as much or as little at any moment that you want it. And there's also no transport time there. From my office, I pick up the phone, I dial the number, and I get the person, or I press the button for the ASL, and the person appears. Within facilities, right, if the person is in 14 ICU and you're in the emergency room, right? Especially if the person in 14 ICU still needs the translator, you're not going to get them immediately. So that's why most systems have gone more to the video or to the phone, just because it guarantees you access at any moment. I think there are situations like difficult family meetings where it would be better to have someone in person, especially if there are multiple people talking and you're trying to understand what's going on in the room. And that's when we tend to use the people who are, actually in person.
The concern I have again is the culture, because some folks are not easy. You can say the same thing on a visual or television or telephone, and then the person that actually talking to them, they will hear that person, but they cannot hear the same thing you say on TV or on the telephone, especially for the seniors.
Yes. And the masks don't help, by the way.
Yeah.
Right. The fact that we're all speaking through masks.
Yeah. And in the communication line, before I pass it, I have seen on TV this lady that could not hear, could not speak, and was sent home and was lost in the train for many days. So how is that communication? Because the first thing I ask myself, how you communicate with a person and you did not speak no sign language, you don't have no Braille available, but you spoke to that person. That raised a red flag for me.
Sure.
So
Understandably.
moving forward, I know you're a smart man. Have you addressed that? That would not happen in our hospital,
Yes.
in the city hospital.
I agree. I mean, again, I've practiced medicine long enough to know you can have huge communication problems in the same language. Right. And anytime you add something that makes it more difficult, whether it's somebody wearing a mask or someone with decreased visual acuity, or somebody with a hearing issue, somebody with different cultural ideas, there are a variety of ways that make communication go badly. And our goal should always be the very best communication and to really best marry what the two people have the same skill to say, whether it's language or it's some other form of communication. But I understand that case you're talking about, and we'll do our best to make sure that never happens at health and hospitals.
Thank you. One of the follow-up question I had with the pay and the staff, that some of the staff still complaining they did not get their COVID hazard pay.
Yes, I've gotten many of those emails.
So how we doing with that?
So the
Doctors, nurses, and
Yes, well, the doctors did not get it except for the residents. The program, just so everybody has the same understanding as the chair, the program was a state program which paid a bonus. It was not for work during the time of COVID. The pay period started after the time of COVID. So one of the complaints people had is, well, I worked so hard during COVID. Yes, but that wasn't the time period the state did the bonuses, so that I can't help with. The state set an absolute ceiling at $120K, so you were not eligible if you earned more than $120K. And they set a variety of job classifications where certain job classifications were covered and certain job classifications were not covered. And they did that because they needed a program that they could administer fairly and that would be relatively simple. The problem is that some job classifications are a little indiscreet, such as coordinating manager. And maybe coordinating manager sounds like a completely administrative job, but maybe during part of the time you really were working with patients, because the bonus is only available if you are doing direct patient care, not available if you're in administration. So what we have done is we have made appeals to the state, and we've succeeded on some of them. So the original rules excluded institutional police, We felt that was completely unfair because their whole job is actually interacting with people. Institutional police is not in any way an administrative job. And we were able to get those included. And even just recently, we sent a letter to the state asking them to consider adding healthcare HCIs, who are healthcare investigators, to the list. But ultimately, the city does not control the program. It's a state program. We can only advocate to them.
Thank you, but on this, at the same time, can you add something in a website? Because this created a lot of confusion, like people feel like it's unfair. You explained it to me, and you said you continue fighting. Maybe that's something you can put somewhere on your website so people can have a better understanding of what's going on when it comes to H&H not getting that money, but continue fighting because we needed them to
Good
feel
suggestion.
love. And the last one before I turn it back to my colleague, I'm doing follow-up question from their question. The COVID-19, now you said the testing is the federal, we got that, but are the people gonna be aware you're gonna have information for them so they know where to get it? Because something may be available. They used to get it in H&H.
Right.
Now they're gonna come to H&H, and then some of them gonna go home and do not follow up from the federal part, understanding it. So people are being trained to make sure they make that referral, so that, I mean, the reference, so people can make sure that, you know, we together on that. We
Correct.
teaching our
Correct.
communities.
So someone who comes to the hospital looking for the COVID test site will be sent to adult medicine if they're an adult, or to pediatrics if they're if it's a child, where we'll have the capability to test them.
Okay. Okay, now I'm turning it over to my colleagues who ask questions. Councilman Barron, Charles Barron.
Thank you. You know, I want to deal with a macro issue around health. We live in a capitalistic government society that prioritizes profit over people. Racism permeates every institution, including the healthcare delivery system. Even Obamacare, so-called Obamacare, the private companies were laughing their way to the bank. Couldn't even get a public option, much less single payer. So they laughed their way to the bank, made mega bucks, but when it comes to the delivery, the service of healthcare to our communities, even countries that they criticize, like Cuba, healthcare is free. The government provides it. Like Angola, poor country in Africa, free. The government provides it. Or Venezuela, who they think you're the worst country in the world, free healthcare. Yet we got a $6.8 trillion national budget, a $102.7 billion city budget, a $227 billion state budget, and healthcare delivery is a problem. Many of our hospitals have to deal with Medicaid reimbursements. That's gone down, the percentage of the reimbursements. A lot of the white hospitals, they have private insurance. So when you cut Medicaid, and especially if you say something like former Governor Cuomo, Medicaid redesign, Medicaid savings, those are cuts. Those are cuts. So my concern on your level, on the city level, even though you're not a city agency, but city services were cut for you too. The mayor cut city services, money, funding for city services, that was cut. When the nurses went out and had their settlement, that didn't mean black nurses, especially if they were $11.99, and some of the other unions we have mainly had black nurses. It did not include that. You say $70, $80 an hour. I know a lot of nurses that ain't hearing that or receiving that. And then definitely not receiving housing, like in some professions, housing is included in it. So my concern is that what is H&H doing differently after COVID? Well, not after COVID, now that it has subsided. Because during COVID, even though we suffered most, black people, we died most, But guess where they build a facility at? The Javits Center, white community. Guess where they built the facility at in the park? Central Park, white community. Guess where the boat that had 1,000 beds on it went to? Didn't go to Harlem, didn't go to East New York, white community. So we don't like addressing the fact of capitalistic greed and racism. And it permeates every institution. And I think we need to speak honestly about it and see how we're going to do some things differently. We had to fight for PPE, we had to fight for testing sites, we had to fight for everything, and we were dying more than everybody. But we didn't get more than everybody. So that kind of behavior has to stop. And I want to know what's in place to deal with those real issues, and then I have a few questions on something a little more micro.
Well, you've set it out, council members, so well. I don't have a lot to add other than to affirmatively agree with you. It makes me proud as a New Yorker that New York City kept health and hospitals. You know, a lot of other cities got rid of their public system. There wasn't the political support. So Philadelphia, lots of poor people, but no public hospital. Washington, D.C., which trained more African-American physicians than any other hospital in its day. No more public hospital there. Not in Milwaukee, not in Sacramento, not in San Diego, not in Boston. That at least New York City, and I think it was because of people like you, kept its public hospital. And I do think while racism pervades everything, at least we have a system where many of the leaders are African American.
Forgive me if I don't give them credit for keeping a public hospital. There's certain things you're supposed to do when you take in public tax-paying money. So I don't give them credit for that. Now that we have it, it needs to really, another minute or two. Now that we have it, it has to be adequately funded. And for the mayor to cut services, and y'all don't say nothing. I know you don't want to criticize the mayor and all of that, but come on now. Every agency is getting cuts from this mayor. Every single agency. So at some point, we got to say that these cuts are unacceptable, and I hope we do that here in the city council. We shouldn't accept the 3% peg in every agency because it's not necessary when you have a surplus and you have $8.3 billion in a reserve budget. So I'm just concerned on how that's delivered. And as far as some particulars are concerned, you know, in many of our communities, when our people come, their primary care is the emergency room, not primary care doctors. So how are we going to address so that poor people, struggling people, can have primary care doctors and not the emergency room?
Right, very, very challenging. You know, sometimes I think that people use the emergency rooms in a rational way. I know that's an unusual view, but the way I think about it is you're a single mom, you got 2 kids, you know, a 2 o'clock appointment at an office is not going to work for you because you don't have any sick leave, or you got to pick up your kid. And that it's not surprising that given the problems with how healthcare is financed and directed here, that the time that you go is in the evening, and you know that if you go in the evening, you can go, it will be open at the emergency department, and that you will get all of the things that you need. And that part of the challenge is that primary care, and I say this as a primary care doctor who loves doing it, is still based on a kind of middle-class model that assumes that somebody can take off for work. And I say to you, council member, I'll see you at 3:30 next Thursday.
I'll say, Doc, could you make it at 6 when I get off at work?
I mean, I'm sorry, sir. I'm only there till 4:30. I couldn't possibly be there till 6. But of course, the ED is open till 6. So I'm always very, you know, I always want to make sure that nobody blames the person who's trying to get the care that they need.
No, I don't blame them. I blame the system for not adequately providing with primary care physicians, you know, for our people, because that's what our people really need.
I agree.
And they do have urgent care now so that they don't have to go to the emergency room, so some places have urgent care when it's not a major issues. But these are the kinds of things around healthcare. I want to commend you, and I very rarely do this in these settings, for your commitment to. Y'all better record this because you will not hear it again. I want to.
That's a great one.
Turn
to
off
get
the
this.
tape. Hey, my buddies, turn the tape off. You got it? Cut it. I appreciate your commitment to single payer,
Thank you, sir.
because that is definitely the answer. I was a co-sponsor with Dick Gottfried and the state on, it's right here. We got a bill right here in New York State, New York Health Act, that has single payer, which will provide free health care for everybody, including immigrants in the state. And that bill is hanging in there, even though you got black heads of both bodies and black mayors and black folk in high places, but that doesn't always solve the problem unless you have people who are committed to the people in those spots. So I commend you for single
you, sir.
payer.
Well, being loved by Council Barron, Charles Barron, you must be doing an excellent job for him. All right.
Oh, no, I didn't say he was doing an excellent job. I said I commend him for single payer, period.
I'm honored anyway, sir.
Yeah, just take it as
I'm
it comes. Grab it. Now, I want to hear from Councilmember Joseph, Rita Joseph.
Thank you, Chair. Thank you, Dr. Katz. Thank you for being here. I have so many questions. I really don't know where to start. I represent Kings County in the 40th Council District, so language access has been something that's very important to me. I represent a huge Haitian American and Creole-speaking community, and that's one of the biggest barriers for them getting care. And the video and the phone doesn't work for them. They want in person. And when I approached administration, from what we were told, I actually sent a letter to the CEO of Kings County. There was nothing in the budget, but when we talk, there's a $10 million language access budget. So how can we work to, we can't make this a cookie cutter. We must really meet the needs of the community and meet the community where they are. So I want to know, how can we make this work for this unique population? It's not unique, there's a lot. You have a huge clientele of Haitian patients. So how do we make it work to meet their needs as well, and making sure that they have care? And I have also mental health continuum question, and I also have maternal health questions.
I can handle this one. I'll take care of it. I didn't realize, again, we do have a large budget, and it does do endless phone. I didn't realize there was a problem at King's surrounding in person, and I'll fix it between now and the next budget hearing.
I would love that, and then we can follow up. Last year, I fought in the budget for something called mental health continuum, and I just wanted to follow up on that as the education chair. It's a priority for me to have mental health continuum. We added about $5 million in the budget for that, and we wanted to provide details, the H&H contribution to this program and how much funding is there for fiscal 2024.
Right. So we think this was a great idea of yours and a great idea of the city's. And we do it, as you know, in collaboration with the Department of Education.
Correct.
And with DOH-MH. I don't know if we yet have a 2024 number. John, do you know?
We do not yet have the 20.
Okay. All right, we'll work on getting that. Is there an extension to support the H&H that you already provide to the DOE? Is there an extension?
We have a 2023 allocation. That would be the sensible extension.
Has the program been impacted by vacancy reduction citywide? I know that's been a...
Again, we wouldn't be affected by that, but it could be that the other parts are affected by it.
Okay, thank you. So in the fiscal 2024 preliminary budget includes $3 million for maternal health, medical home, and OB stimulations. I was at the ceremony with BP Reynoso when we gave about $15.5 million to our maternal health program. That hospital is also in my district. Can you provide a breakdown of the $3 million? How much of the funding will go to personnel, training, equipment?
Yes. So you have the number exactly right. It's 3 million for the maternal medical home and the OB simulations. It's 11 training mannequins and the construction and outfitting of 6 mini sim labs. So that's the sim lab part. But what I'll have to provide to you after this is the budget on how the 3 million is being spent on staffing. That I don't have here.
Okay, and who will qualify for the maternal medical home? What are the qualifications?
Any woman who is coming to that hospital will be offered a medical home. That's just as we would offer a primary care home to somebody who needs primary care. The whole idea is that good maternal care should be seen as an interdisciplinary thing. It shouldn't just be the OB. It should involve midwives, it should involve doulas, it should involve social workers, and that
A holistic approach.
Right, every woman should be able to
Oh,
get
absolutely.
that level of care.
Absolutely. How many midwives do you have? Does H&H have on staff?
So we're growing our midwives. 7 of the 11 facilities have existing midwives. Historically, we have not had midwives at all of our facilities, but we've made a decision, mission-based decision, that we're now hiring for all 11 hospitals midwives. I don't have the number of midwives, though, through the system that we'd have to provide.
Chair, can I just, thank you. How many doulas do you have?
So the doulas are all through the city's CBO program. So they don't work for health and hospitals, but we refer any woman who asks for a doula.
What's your
we think we
CBO
would
partnerships?
benefit.
Who are your partnerships?
I don't know the list. I just know that it's a city-funded program. The obstetricians would know, but we'll find out the names.
Thank you. Also, what are we doing with our paid parities for our H&H nurses?
Well, I think
That's going to be the biggest topic you'll hear
right,
about.
yes. I mean, we're going to have a positive contract negotiation with NISNA. I really believe that. I really believe that NISNA has always been very supportive of us, and we've always been very supportive of NISNA. I think while they recognize our challenges, they often say that we treat them as professionals in ways that they don't always are treated in other hospitals. So I'm very hopeful that we will have a positive negotiation.
Yes, we hope so, because pay parity is very important to this council. For the city, we saw they step up during COVID. I'm married to a nurse, so this is personal. Yeah, real cool.
They were amazing.
Now you know.
They're amazing.
So I have to make sure that their voices are heard. He's not here, but my nurses, we care for them just as much as I care for teachers as a forever educator. So we want to make sure pay parity is at the front of centered in this conversation.
Understood. Thank you.
Thank you so much. Thank you, Chair.
No problem. Now I don't have to follow up for the Kings County because I didn't tell you. I told you I'm going to call you, but she put it on the table. That's Kings County. When I told you Creole in the middle.
Did mention that it was a hospital in the center
in the center of the Haitian folks.
Which did provide us something of a hint to me, since I do have 3 hospitals, 1 south, 1 north, and 1 in the center.
Yes, center of the Haitian population. I believe that even in Haiti, they know about Kings County. So, when it comes to doula, the follow-up question that I have, can you give me a number by facility that have doula, the numbers?
So they're for us, doulas are an external referral because they're paid for, the city pays, but the city pays via a DOHMH contracting with community-based organizations. So that's how we do it. When we think a woman would benefit or she thinks she would benefit, we call to the CBOs and arrange for her to get a doula.
Okay. For facilities that don't have a midwife or doula on staff, does an H&H, because you don't have the staff apparently, you have to call the CBOs. Does H&H have contracts? Which CBOs that you have contract with for the doulas?
Again,
Is the-
they're all through DOHMH, but we,
All
like
of them,
other
okay.
hospitals, can refer. And I think that was done so that other hospitals
Can
in
use-
Brooklyn can
utilize.
also get doulas for their patients.
Okay. Now I have to call on my colleagues here, CM Wrestler.
Thank you so much, Chair Narcisse. I really appreciate the opportunity to be with you and your terrific leadership of this committee. And Dr. Katz, it is always good to see you.
Pleasure, sir.
You are a treasure, and we are very lucky to have you serving the city of New York. Even Charles Barron approves. That is I think that's the first time that's ever happened. Yeah,
I could
that's
not
the
believe
first.
that one.
So that's-
I was out of
I
my
don't-
mind.
I hope
I said,
somebody
huh?
got that on video. So I will just briefly, as an aside, as you said so well, nobody is a better champion for our public hospital system than NYSNA. They have been forever. They always step up and fight to ensure that our public hospitals have the resources that we need. And I've seen contract negotiations that you've navigated with them in the past that have been amicable, that have led to good outcomes. We need that to happen again and hope that it will here as well. And I really just want to echo a couple of the sentiments that Councilmember Gutierrez brought up so eloquently. 20%, as much as 20% of the patients we see at health and hospitals are undocumented. None of the voluntary hospitals see anywhere close to that. So we are the safety net hospital system for the city of New York, and I just think it echoes the sentiments of your CFO. We need to do so much better in Albany than we currently do when it comes to DISH funding, when it comes to getting the safety net funding that we deserve. Our public hospitals are the place that serve uninsured New Yorkers, and we deserve to get the resources that demonstrate it, that back that up. So I just want to thank you for everything you do. Also appreciate your sentiment that Be Heard is moving, that the growth of Be Heard is a good thing for New York City, but we need to always be refining it and reforming it and improving it. And I know you didn't have the data at your fingertips, but we know that a modest minority of the 911 mental health calls are actually going to be heard. We want to see that number exponentially expand. And so that the social workers and the EMTs that are responding to these calls are able to engage as many people who are in need as possible and respond in real time to provide the assistance and support they need. And I think there's been a lot of advocates who have had constructive criticism to how to make it a stronger program, and I hope that H&H will be open-minded in continuing to reform and improve it. Two areas I just want to ask a couple questions on today. One is on vacancies. We've been talking with every agency head in the city about the vacancy rate. I don't have that data in front of me. Do you know the current vacancy rate for H&H?
I do. It's 23%.
23% vacancy rate. And do you have that broken down clinical, non-clinical?
I don't have it here. I just do want to say that doesn't mean that there's nobody working. That's 23% of the full-time positions are empty, and so that's why we have to hire so many temporary nurses or registry nurses so that we're able to deliver the services.
Do you believe that that is predominantly the nursing shortage that we're facing and why
Yes, because we know that we currently have 8,000 nurses and permanent, and 2,000 are working as temp nurses, which is 25%, and that's our largest single group. And again, that's not what we want.
Right. Well, hopefully, with improved salaries in a new NYSNA contract, we'll be able to attract more NYSNA nurses,
Yes.
retain more NYSNA nurses, reduce our reliance on these extremely expensive traveling nurses. It would be very helpful to provide a clinical and non-clinical breakdown on those vacancy rates. I'm interested how H&H is doing in comparison to the rest of the city. Are there, I'm interested in understanding if there's more that we can do to help you to support hiring and where the gaps are beyond nurses that you're really prioritized, that you've prioritized, or if there are particular areas. But just because I'm short on, let me just pause on that. Are there areas other than nurses where you feel like there are major gaps or vacancies that you need to be, that we can be good partners in prioritizing hiring?
Mental health, and we think there are a few possibilities. One, we've done a loan repayment in collaboration with the mayor. We think that loan repayment is the single best way, because then we're attracting people from communities that serve our patients, and then they have a commitment to stay with us. So we would really like to do more loan repayment. We also think, and we're trying to work with the state, that there needs to be, around mental health, some greater flexibility around interdisciplinary teams, because we have to accept there are just not enough psychiatrists. And if all the work is going to be said to be done by psychiatrists, we're going to have closed beds, because there just are not enough psychiatrists who want to do inpatient hospital work. They're able to do counseling often by Zoom, and they're not prepared to do inpatient work. And so we need greater flexibility with the state in training people for other jobs, as well as for allowing people to cross over and do useful work as, say, a pharmacist, as a nurse, and in other capacities.
Great. Speaker Adams raised the notion of social work fellows in her state of the city. If there are other ways in which we can be supportive to build out the pipelines in these areas, to support workers in these areas, please let us know. We'd love to follow your lead. Would it be okay if I did one more topic? Thank you very much, Madam Chair. I'd like to ask about therapeutic beds, and it's good to see you, Dr. Yang. My recollection was that these nearly 400 beds would begin to come online, or were slated to begin to come online, in December of last year. We all know how horrible the conditions are on Rikers Island today, deadlier than ever for the detainees that are there. These are beds that should have already been taking people off Rikers Island to provide high-quality inpatient care to people with serious physical health needs, chronic health conditions, and yet I can't get any understanding of a timeline. Where are we? This is fully funded? I know you're deeply invested in this. At Bellevue, at North Central Bronx, and at Woodhull, and Councilmember, well, it's actually in Cheese District, I know, but it's like across the street from Jen and me, and Woodhull. Do we have timelines for when these beds are going to come online?
Yes, thank you for asking. We totally agree about the importance of these beds. Bellevue is still in the works, very much underway in construction. The target date right now for Bellevue for construction completion is the end of this year.
Okay.
And still planned is 24 and 25 for Woodhull and North Central Bronx, respectively.
24, 25 completion. Start.
That is the plan
Has
right
there
now.
been any movement on either? Is DOC cooperating in any way on either of these locations?
They are. We've been working with this administration. They have identified a number of design issues that affected their ability to manage and do custody management the way that they need to.
Have those issues been resolved? Have those issues yet been resolved?
We are about done with resolving them.
Okay. My understanding is that DOC was totally non-responsive and in engaging with H&H on this, and came very late to the party to flag issues, and have not been easy to coordinate with, and it has delayed this process unnecessarily. And if there are issues of coordination and DOC is not being as responsive as it should, we want to be aggressively, proactively, consistently pushing them to do their jobs. And so we are deeply concerned about the delays and the lack of confidence in the 2024-2025 timeline. That's next year. When we haven't seen any actual movement at Woodhull, any actual movement at NCB, it's very, very disconcerting.
Yeah, our focus right now is very, very much focused on Bellevue, and getting that up and going.
And are there any major obstacles that you're concerned about that you'd like to put on our radar?
Not at this time. I think we're working really closely with the department as well as with OMB and everybody else.
Who's the point at DOC?
There are a number of people. I deal with the commissioner on this project, and I know he understands the importance of it and supports.
You feel that DOC is invested in bringing these 400 beds online?
Right now, we're really focused on getting Bellevue done this year and see how that goes.
We want to help you make this happen.
Thank you.
I don't believe 400 beds is enough. And considering we all know that Rikers is the largest psychiatric facility in the state, we need more capacity at our hospitals to connect people to the care that they deserve and to treat people with humanity and dignity. And I'm very concerned that we don't have an administration that is committed to this and that things are moving far too slowly, and it's at the expense of people's lives. So one of my constituents is in Rikers Island today. He has serious mental health, serious substance use needs. He will not be help there. It is not where he belongs. And we have solutions, but it's a lack of political will that are slowing them down. So thank you for your work.
Yeah, appreciate your support.
Thank you. A follow-up question that I have from what I'm hearing. Perhaps you can answer that. Do you believe that we're in better shape to deal with a pandemic more than like 3 years ago, with the shortage, with the cut in the budget, shortage of nurses?
We are, in the sense that we've learned a whole lot during COVID about sort of emergency preparedness, emergency communication. We've learned to turn on things. I mean, I think the success of sheltering 9,200 asylum seekers occurred because we got so good in COVID at creating residences for people when we were trying to isolate them, that those same reflexes of, okay, you know, we have hundreds of people coming off a bus now and we need to take care of them. All of a sudden we knew how to do that because we had done it, we had learned how to do it under COVID. So you never know what the next emergency is, you know that, right? It's a weather emergency, it's a man-made emergency, it's a biological emergency. But I do feel like practicing emergency planning, emergency communication over the last 3 years has made us a lot more adept at making change and making things happen quickly.
Yeah, because that's what brings me to it, talking about nurses shortage. Because what we went through this pandemic, I'm always terrified for anything else happen, and we're not really addressing the core problem, which is the backbone of our healthcare system. So when I hear about like we need to do something, I believe that you understand the urgency to make sure we have enough nurses in our hospital. All the staff, but nurses hold the hospital going.
I totally agree.
So asylum seekers. Of the $1 billion in federal funding added in November 2022 plan to fiscal 2023 for the city's response to the asylum seekers crisis, $310 million, or 30%, was added to H&H budget. This funding was later reduced in the preliminary plan by $7.3 million by shifting funding to DOHMH and HPD. Can you provide a breakdown of the over $302 million by expense type and purpose? For example, how much is allocated to HERC, cost support services, language services, food, and other expenses?
Sure, we'd be happy to provide the council with all of those contracts. I'll just say on the shift, we've always done this with our sister agencies. And so some of the shift was just simply that responsibilities that we first thought would be done by us are actually going to be done by DOHMH or HPD. So we just switched the money. It's not any decrease in expenses. But yes, each of the contracts has a detailed amount that explains how much is food, how much is translation. I understand that 90% of the staff that we have hired to work at the HERC are Spanish speaking. So we have not had a large translation expense because we've been able to hire people who speak the same language. But yes, the contracts go over down to the dollar what each of the expenses is.
Okay, I did not see it, so if you have not sent it, whoever is supposed to send it for us, can you please provide it?
We'll resend.
Thank you. Why was this amount reduced by $7.3 million since the city has added new HERCs since the release of the preliminary plan? What is the actual spending to date on the HERC? How much total has been spent citywide on HERCs, and how much is projected?
The 7.3 went to our other agencies. So that's just so DOH and HPD can do their portion of the job. The city estimates total spending at $1.4 billion in fiscal year '23. How much have we spent to date, John? Do you know that?
141 million to date.
100 what?
141.
141 million.
As of January 2023.
Okay, what is the timeline for vendor selection in an emergency? How many vendors is H&H working with?
So we're working with 13 vendors, and part of why it was done via Health and Hospitals is as a state-created agency, we can contract more rapidly, and that enabled us to provide the services in a timely way. Our board reviews the contracts and can terminate any vendor if they haven't met the deliverables. So also reviewed by OMB prior to any contract being executed.
Thank you. This one I'm very much interested in it because I used to be a vendor and I know how difficult that can be. Can solicitation for emergency procurement include cost flexibility?
Yes, it can.
Okay. How does H&H work currently? Coordinate the needs of asylum seekers with NYCEM, MOYA, CBOs, and other agencies?
New York City really should be proud, I think, of how it's handled the asylum seekers when you consider how other cities put them on buses, right? I'll never forget the woman who came off the bus with diabetic, having had nothing to eat, the other woman who was pregnant and about to deliver, the person who said, I thought I was going to Oregon when they got off the New York bus. Well, we've handled everybody with respect and with an aim to help them. We work closely with the sister agencies. We figure out who does what. It's a very successful model. NYSEM, for example, does facility management at the Brooklyn Cruise Terminal. DOE provides the on-school enrollment. So I think it's been a great success.
Mm-hmm. How much is H&H spending on contracts to help the system manage the HERC? How many contractors that supported H&H during COVID have also contracted to work on the HERC?
I don't know that figure. I'll have to get back to you on that figure.
You know why I asked that question too, right? It's because that if they were there present to help, they were contracted, I would continue doing business with them.
Ah, okay, got it.
And I know that a lot of Black and brown communities were out there helping out.
They sure were.
All right. I have a question on Medicaid rates. The proposed state budget include a proposal to increase Medicaid rate by 5% for inpatient and nursing home, but that may not be sufficient to keep up with the cost and inflation. What does the 5% rate increase mean for the finances of the system? How much would H&H expect to receive if enacted?
If it was enacted, we would receive $80 million. But the reality is that the state has made other cuts to us at the same time. And so if you add the additions and the cuts, it basically leaves us even. So we will not in the end have any additional dollars, which is a problem because of how much healthcare inflation is running. Besides, we've talked a lot about the staffing issues. We haven't talked about drug costs or other kinds of durable goods costs, which are running at least 6 to 8% higher than last year.
Let my CM Gutierrez has a question that's burning in her. So
Thank you.
ask.
Just one question. Thank you so much. Chair Narcisse, for your generosity. So I just wanted to know if you had any ability to update the council on some of the maternal mortality bills that were passed last summer, I believe. It was regarding increasing services to midwives and doulas in some of the 13 neighborhoods as deemed by the administration's racial equity study. And a number of us were on those bills, sponsored those bills, mine in particular. I can give you the bill number, but part of it was obviously also creating a pipeline for more doulas, as well as a report by 2024, more or less, to assess kind of the need. So just curious if you have any information on kind of where you are. The program, to my knowledge, was supposed to start immediately, and obviously talking about, Councilmember Joseph brought up the importance of midwives and doulas, as well as Chair Narcisse. I was lucky to have one at Woodhall. That's where I chose to deliver my baby. I think that service is transformational in keeping our communities alive and healthy, which is why I was so happy to have passed that legislation. So just curious where you are at. I think that's an area that me and the administration are very much aligned with and in agreement about. So curious to know if you can give any updates on where that's at. Thank you, Chair.
Well, so that bill, and thank you for your support of the bill. Thank you for having your baby at Woodhall. That's a nice endorsement of the wonderful midwifery program at Woodhall. So yes, that bill was instrumental in the creation of the maternal medical homes and making sure that those homes are interdisciplinary, that they include midwives, that referrals to doulas, that they include social works, that they include looking at all of the social determinants, access to food, transportation, housing, substance treatment, mental health, legal services, all the things that might make a difference. And we've been able to switch all of those programs from a more traditional woman goes to see an obstetrician to woman is supported by a whole maternal home staff of people whose whole goal is a healthy mom and a healthy baby.
Is there anything that you can speak to regarding the doula training program? As I understand, the bill calls for the city hospitals employing up to 50 doulas and just creating that pipeline. So is there anything you can share on that? And that's bill number 472.
Yeah, I have to get back to you on the doula training program. I don't know that.
Okay, thank you, Chair. Thank you so much.
End of public health emergency. New York City Health and Hospitals announced plans that last Friday to downsize its COVID-19 testing, vaccination and treatment. We spoke about that earlier. Operation in preparation for May 11 expiration of the federal pandemic emergency declarations. H&H is set to close its COVID testing tent and relocate operation to its outpatient clinics. Its fleet of 40 mobile test to treat units will reduce to 20. Where are the outpatient clinics where testing will be available after March 31st located? How is H&H choosing this site? 2, H&H plans to reduce its fleet of 40 mobile tests to treat units to 20. What financial steps has H&H taken as a result of the end of the public health emergency on COVID?
Right, so for everybody's knowledge, May 11th, when the federal pandemic emergency ends, so does funding through FEMA. So at that point, all operations will be purely paid for by the city, by health and hospitals, by private insurance when people have it. So with that, and also with the markedly lower numbers of people getting COVID, especially people getting very sick in the hospital, everything will shift to our normal way for providing care, and that's the 11 hospitals and the more than 40 outpatient sites, including the 14 Gotham federally qualified health centers. And at all of them, we'll vaccinate people as we vaccinate them today for tetanus or pneumococcal vaccination. And we'll test them for COVID just as we would test them for a strep throat. We'll make the care for COVID part of our standard care. We will maintain the test to treat units, as we know that Paxlovid, despite its effectiveness, remains underutilized, and we will still maintain the 212 COVID-19 hotline, because we think that there will always be a need for people to be able to call us up if they're not sure where to go.
So, because I think Councilmember Barron's alert to this, like, during the height of the pandemic, we lost so many lives, but yet, Black and brown communities, and yet we did not get, our fair share in delivering of care and the testing and stuff. So now, as we scale down, would you, I don't want to ask that question, I'm going to ask you directly, would you be distributing them or locating them strategically to address the inequities in our community?
Yes, absolutely, and that's part of what we do always.
All right, thank you. Aside from testing site and mobile unit, what are some of the activities that H&H plans to continue to provide in FY24? Testing, medication, I think you answered most of them already. How sure are that gaps in services will result as the end of the PHE?
Well, I think the biggest one is our virtual express care, where we've had a lot of success connecting people directly with an emergency medicine doctor or nurse practitioner, and be able to direct them to further care, or get them on Paxlovid, or get them their appropriate treatment. So that resource will remain, the virtual care, the 24-hour phone line will maintain, the 20 mobile test to treat units will be maintained, and then all the other services that people are used to, they'll still be able to get at our hospitals and at all our Gotham Health clinics.
So the end of the PHE is not going to cause too much?
I don't see it, no. We're currently, part of what we've noticed is even before we got to the May 11th deadline, the demand, say, for COVID testing is very low, because people have learned how to use the home tests. And frankly, the home tests are better because you're not exposing anybody else. So it's actually, in this case, it's not less than, it's more than. If you have a home test, better you should do the home test than you should go on the bus to the hospital to get tested and expose a bunch of people on the way. So, and we can, through the COVID hotline, if people don't have tests, we can get them the tests. So there are a lot of different ways that I think we can make this work.
I appreciate that, because I give the tests in my office. I encourage it for every event that I do. I do food giveaways every Monday. I make sure I have enough tests for everybody. The budget include $354 million in funding for COVID-related services. How will H&H expect to use this new $190 million added in the preliminary plan? Does H&H expect to be reimbursed for these services by federal funds in fiscal 2024? Does this funding cover any surge or wave in COVID positivity rates? And how confident are we that we are well equipped to handle any unexpected surges?
I feel pretty confident about our ability to handle any crisis at this point. Having lived through 3 years of crises, my level of confidence for us is very high. The 190 is, we will attempt to get federal reimbursement for it, but if not, right now it exists in the money in the budget as city dollars, and it will continue to pay for the services that we are already delivering, and will continue to deliver into the next year. So it's not a new service, it's a continuation of our services.
Thank you. Mental health beds. At the start of the year, H&H reported to the council having 928 inpatient behavioral health beds currently available, with the anticipation of opening at least 200 more IPBH beds in the coming year. H&H also reported it's conducted a financial analysis for costs associated with staffing and capital needs to open additional beds. The reopening of planned beds in psychiatry will, of course, involve staffing up the units that were closed, conducting environmental work, or some units to ensure they are up to code and mitigate the risks, any risks to it. So how many psychiatric beds are currently available at this moment in H&H system?
So at this
What
mo-
is,
Oh, sorry, go ahead.
that's okay. What is the occupancy rate right now?
So right now, we have 1,000 psychiatric beds with an occupancy rate of 79%.
That was fast, thank you. Have you completed this financial analysis on the cost to open more beds? Do we expect funding to be included in the executive budget? What is the ratio of staff to beds that you are aiming for?
Well, John does the finance question. The ratio of staff is 1:7 on nursing and 1:15 on ancillary personnel. Can you answer
And on the number, it ranges between $650 and $700 million is what we're anticipating. There's also, revenue that would offset those costs, as we're providing services to those that are insured.
All right. Is H&H expecting any resources from the state to reopen these beds?
Well, the state did provide about a 20% increase to the fee-for-service rate for psychiatric, services, which was helpful. The issue with that is that, the minority of the services we provided are on a fee-for-service basis. The majority really comes from Medicaid managed care. So we are advocating for increases from the state as it relates to, and hopefully, comparable increases as to what they made on the fee-for-service side. But yeah, we're always in ongoing conversations with the leadership at both the Office of Mental Health and the Department of Health to make sure that our beds are adequately resourced and reimbursed.
Thank you. Asthma COPD, Community Healthcare Worker Program. In March 2023, H&H informed several community-based organizations working on the Asthma Community Healthcare Workers program that H&H would not renew their contract in the fiscal 2024 budget. This program, originally funded by New York State 1115 Medicaid waiver redesign through One City Health, focused on reducing available hospitalizations among New York City children who suffer from frequent or severe asthma attacks. H&H now plans to use its in-house generalist community health workers to take over the CBO work. Can you describe the success of the program and describe how much it will be funded from in FY24?
So I have only good things to say about the Asthma Community Healthcare Worker Program, which I think was great. The issue is that it was funded by the New York State 1115 Medicaid waiver, which has since ended. And so the dollars, there are no dollars from One City left. Because we recognize that it is important to still be able to do the work, we've asked that our in-house community health workers take over the mission with training, because that would be a way of maintaining the service. It does also have the advantage, now that we've been doing in-house community health workers, we do see the advantage that when they are part of the care team, it is often easier to work with because primary care doctors like me can make the referral to the community health workers, and the community health workers can see my notes and can chart back to me how the patient is doing and be part of an interdisciplinary team. But the overall issue is the ending of the one city contract.
So there's no possibility to hold the CBOs?
Not via one city. That program has ended.
I have some concern as a nurse, because all those folks we're seeing by CBOs that's already used to them, familiar with their cases. I used to do home care, by the way, too. So now suddenly they're coming to the hospital. Would they come to the site, really? Because they're already used to that environment, and some of them knows those patients for years, probably. So that will kind of put a hole in the continuity of care for me.
I understand. I mean, Health and Hospital is not a funder, right? Once the waiver was a funder, and we administered it, and I think it was a great program, but that program went away, and Health and Hospitals in and of itself is not a funder.
So my follow-up question with that, what is the effort that H&H is making in reaching out to those clients that have been getting cares from those
Right.
CBOs?
So what we'll do is, as long as, of course, always respecting client confidentiality, because they may be not one of our patients, and then we would need to seek their permission. But our community health workers can reach out and continue the same services that those people were getting, as long as we have their permission to reach out to them. If they were, I'm assuming some of them were already outpatients, say they went to Woodhull. Some of them probably weren't outpatients, they went elsewhere. We could certainly, with permission, reach out to them, even if they're not our patients.
What's the possibility of working with the CBOs and doing it in transition instead of, there is no possibility? Because my concern is about the patients,
Right.
because how are they gonna get that continuity of care?
Right.
Because asthma is the big thing, especially, I would say it again, Black and brown communities.
Sure.
And not getting care.
Right, I understand. I just don't have an alternative funding mechanism once the one city ended.
Currently, H&H has over $1.7 billion in FEMA grant funding for Superstorm Sandy repairs, $922 million for South Brooklyn Health, $498 million for Bellevue Hospitals, $180 million for Kohler Hospital, and $120 million for Metropolitan Hospital. Can you provide an update on how these projects are doing?
John, you gonna
Yes,
do that?
yes. Yeah, I would say, first, we're very, grateful for the FEMA funding. It's allowed us, we spent over $1 billion of the $1.7 billion that's been allocated to us. It's allowed us to build a new hospital on Coney Island for $922 million, and which is, if you haven't been to it yet, it's
I've been to it from the beginning.
Yes, it's fabulous.
To the
If something bad, came out of something good came out of a very terrible storm, right? I think that is one for us to be thankful for. That's 90% complete, and we expect it to be, fully operational in 2024. The other projects at Bellevue, Metropolitan, and Kohler are related to building flood walls, right? And to protect, our facilities in the event of, unfortunately, if there were to be another storm of that size. The completion date at Bellevue will be in 2030. At Metropolitan, estimated completion date will be the fourth quarter of 2024, and at Kohler, projected completion date of 2031. So
20, what for Kohler? 20 what?
2031. We're in frequent contact with FEMA about making sure that they understand that we are continuing to aggressively pursue, these projects. And we've assured them that they will be brought to completion, and whatever funds that we don't use, we will obviously return back to the federal government.
Okay, thank you. 10-year capital strategy. The majority of H&H 10-year capital strategy, $3 billion or 80%, is projected for routine reconstruction, following by funding for EMS equipment. How much of this routine reconstruction funding for repairs related to making H&H facilities more accessible? How much funding does the city project to spend on new facilities, especially for communities without H&H facilities?
I would say, I think Dr. Katz could probably speak better to this, but all of our facilities have to be ADA compliant, right? So we build to those, obviously, to those specifications, and and where we can, right, we go beyond those specifications. In terms of a breakdown of the $3 billion, we would be certainly happy to provide that to you, along with any other details you'd like regarding the capital plan. We'd be happy to have a separate meeting with you on that plan, as well as other elements of the budget that we've presented today. I'll say I'll just say this because I haven't said it. It's nice that we're in person meeting together, and prior to COVID, we used to get together with council staff and go through whenever we produced our financial report to our board. We thought that was a very helpful way to keep our communications open about our performance and achievements. Yes.
Mm-hmm. All right. Street Health Outreach and Wellness. The Street Health Outreach and Wellness program utilizes mobile units to provide health screenings, vaccination, wound care, basic material necessities such as socks or bottled water, behavioral health and social service referral supports, and harm reduction services to New Yorkers who are unsheltered. What is the total funding for this program in fiscal year of 2024? How many of the 8 vans do we currently have on the street, and how is the program is running?
It's $18.1 million in total funding, and I'm happy to say all 8 vans are currently operational.
Thank you. How many new staff positions does the program have, and what are the titles? How many service referrals have you fulfilled through these vans, and what are the most requested services?
So the vans have physicians, patient care associates, social workers, clerical associates, addiction counselor, peer counselor, security person, and a driver. And we've done
Security and drivers?
And a driver.
Okay, that's,
To drive
thank you. Got it.
Yeah, the van itself. And we've provided thousands of services with behavioral health being the #1 service that we do. We also do social support, substance use treatment, food, finance, employment, and help to house people.
Thank you. Cash plan. H&H cash plan shows the system receiving $1.58 billion in funding for the city services in fiscal 2023. However, OMB's financial documents show the system receiving $1.78 billion from the city from the same period. How you explain that?
Yeah, I'll say both numbers are correct. The city reports its finances primarily on an accrual basis, and health and hospitals on a cash basis. So it's that conversion of the two, but both numbers are accurate.
Thank you. Okay. Can you reconcile, you just reconciled it for me. I'm not gonna ask you that again. What is H&H cash on hand as of today? How many days does that cover?
Today was a good day for us. We had seven.
It's a good day for me too.
It was a good
it's
day.
Nice outside.
We have good days and not so good days, but today was a good day with $750 million. Yes, $750 million. We got a big payment from the state that we've been looking for quite some time, and that equates to about 30 to 32 days of cash on hand. We pay attention to the days cash on hand. It's very important that we obviously have enough cash to run our operations, but 750 is the
750?
Yeah.
Okay. H&H cash plan anticipated operating loss for the next 2 years, 144 million in FY23 and 110 million in FY24. What are the major driving forces behind this loss? And what is H&H doing to mitigate any impact on the system?
Yeah, I think we've kind of spoken to this. I mean, the 144 million and the 110 million are primarily driven by the cost of the temporary staffing, across the organization. Also within that, there's been delays in payment from the federal government, CMS, and the state. So we're anticipating, continued delay, but we will do our best and work our hardest to try to bring those dollars in sooner. We've notified, both the state and CMS the importance of being timely with their transactions with us. But again, I think the real cost pressure is a combination of the temporary staffing costs as well as just general inflationary pressures on our supply chain, like drugs.
Okay. So some of the money will go to regular nurses, our city nurse soon.
Yes.
So you don't have that problem. Preliminary Mayor's Management Report. Regarding the NYC Care indicators, it shows that total enrollment is 105,070, but that does not mean that H&H signed up 105,000 folks in the first 4 months of the FY23. It is simply the achieve that number of the total enrollees, correct? Just as H&H did last year with 100,000. Can you answer that one for me? If that is the case, then shouldn't the indicator include the number of new enrollees sign up in the first 4 months, not the total populations of enrollees? What are your thoughts on the proposal to add all low-income immigrants to the state essential plan waiver and how it could benefit H&H and safety net hospitals?
We're totally in favor of adding all undocumented person to the waiver,
Okay.
so that they would be covered, and we think that would be a great boon for their health and access. And we can work with the mayor's management team on what the best way to show the data of both. Both numbers are valuable. How many people are currently in the program is valuable, and how many people got added to the program is valuable. So we're happy to work with them on that.
Okay, thank you, because data help. Metro Plus membership. Similar to NYC Care, the PMMR reports the number of individuals enrolled in the time period, but not the number of new enrolled. Shouldn't the metric on Metro Plus membership to focus on the growth in the period rather than the total number? How many new individuals have been able to enroll in Metro Plus?
I'll have to get back to you on the number of new people who joined in the last period of time. But as with the earlier one, I'd say that they're both valuable numbers. I mean, you as a policymaker, you want to know how many people are in your plan. And you should know it's 700,000, and that's something that we should all be proud of. It's right to also know how many are new members. So we'll figure out with them how to show both numbers.
Thank you. We want to make it work with you, Dr. Katz.
Oh, thank you.
Okay. Correctional health services. Considering that violence, serious injury, stabbing, slashing, assaults have rising in the city's jails, has CHS budget seen a corresponding increase in the resources? Can CHS give the committee an estimate of its needs? Can CHS provide an update on all of the options available for discharge planning for a person exiting detention? If a person has both a physical and a mental health condition, how do the two different type of care coordinate?
Thanks for that question. We have not needed to increase our budget, but nor have we seen a decrease.
Can you
in our-
speak a little louder for me?
Sure.
Because I have to take notes.
We haven't needed to increase our budget, but we also have not decreased it. We continue to recruit and staff who can handle the patients who need to be seen. Regarding reentry, we begin on day one on a person's admission into the jail system to begin to prepare them for leaving jail and hopefully not coming back to us, depending on what their individual needs are, because the services are very patient-specific. Whether it's a medical or mental health issue, we will begin working with them to make sure that they have all the public benefits that they need, including, very importantly, Medicaid. We work with community providers, and especially health and hospital system providers in the community, to connect people to care if they've not already got a provider in the community. With appointments, we give people who need medication their 7-day supply, for example, for people who are on psychiatric medications, as well as prescriptions in the community for a 21-day supply while we connect them with a provider.
Thank you. By the way, I used to work in reentry program, and one of the things that I used to see a lot, that they're being discharged and they're not getting enough information, but that was a few years back. I hope by now everything got situated better, that people is not lost in the process. So when they come to you, by the time they come out, no arrangement made whatsoever. So with technology is the biggest things, that they don't know how to use a phone. They don't have no kind of, we call it reentry, so it should be planning way before the person being discharged, especially those that have a lot of mental health needs. Capital funding has been committed, for nearly 400 outposted therapeutic housing units at Bellevue, Woodhull, and North Central Bronx, to move people who are in the city jails with the most acute care needs to the hospital. I think Wesley touched that already. I think you answered that one too, so I'm not gonna ask you for myself. Has CHS budgeted for the staff you think would be necessary to operate this unit, and how many staff is that? I think he had probably, did he touch on that one?
Yeah.
What was the number again? I forgot that number again. Okay. How many staff that you need to operate?
So depending on the patients and their clinical needs, they will be moved to the therapeutic units that are the first units will be at Bellevue. Our staff will be moving with those patients. These are not new patients. They're patients who are the most clinically vulnerable or fragile, that are going to be moved off-site. So we will go with them.
So right now I can say that, to be safe, that you have enough staff
We do
to
have
do the
enough staff.
transition
Yes.
that you have
Yes.
with the beds? Okay. Mental health, I think somebody asked some kind of question on mental health. The priority of this committee is mental health. I think by now you know, guys. Mental health is very important to us. Last year, the city added $5 million. I think Chair Joseph asked that question, but she didn't ask you that part. Is this an extension to, okay, I think she touched that. Has this program been impacted by the vacancy reduction? I think you answered that one, did you?
No.
Can you answer that? Has this program, the program that we have right now, impacted by the vacancy reduction?
No.
No. Okay. Thank you. State budget. The state budget included several proposals that, if enacted, will negatively impact H&H. I think you answered that one for me too. I don't have to ask you that question again.
Good.
So, because you give me that answer, I already have that. I think I want to give everybody a break for 5 minutes. Dr. Katz, I appreciate your time. You've been great, so I thank you for answering all the questions. But now you know where our needs are and what we like to see in the city of New York. Prioritize it by making sure that we have enough staff, and that come with the nurses, because we need to keep the hospital running, and I don't want them to leave the state of New York.
Yes.
Because I have a few friends that call me, they're gone. So let's keep
Let's
our
get 'em
nurses
back.
home.
Let's get them back.
Yes, so thank you.
Thank
you
you.
for your testimony and answering the questions, and have a good evening. Thank you so much.
too.
If-
It's an
if you
honor
don't
to
have
be
any-
here.
I will always said, I will advise you if you can, anyone can stay, because we're gonna have the testimonies, but I know it's been a long day, so I thank
In
you.
our case, I have a public hearing in Staten Island, so now I'm going to go to that hearing.
So thank you.
Thank you.
Drive there safely or get the train safely. Thank you. Oh, no.
Hi all. We will be taking a break, 5 minutes break, and we will begin public testimonies afterwards. Thank you.
Oh, you want even time?
Too late too. Hello, everyone. We will be starting at 5:15. Public testimony. Thank you. Okay, we will now hear from testimony from the public. I would like to remind everyone that I will call up individuals in panels, and all the testimony will be limited to 2 minutes. The first panel will be remote. So if you are testifying remotely, once your name is called, a member of our staff will unmute you, and you may begin once the sergeant at arms sets the clock and cues you. So the first panel would be Dr. Diana Jabber, Dr. Michael Zingerman, and Dr. Anju Rao. Oh, none of it? Okay. 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 Apologies. We will now begin hearing, hear public testimonies. I would like to remind everyone that I will call up individuals in panels, and all testimony will be limited to 2 minutes. We will begin by remote panel. So if you are testifying remotely, once your name is called, a member of our staff will unmute you, and you may begin once the sergeant at arms sets the clock and cues you. Our first panel online would be Dr. Diana Jabber, Dr. Michael Zingerman, and Dr. Anju Rao. Dr. Diana, if you're here.
Starting time. Hello, I'm Dr. Dina Jabber, and I'm a resident physician at Kings County Hospital, and I'm also a regional vice president for CIR. I'm testifying today on behalf of thousands of resident physicians at the H&H system who are part of the Committee of Interns and Residents to say it's absolutely crucial that every city council member stand against Mayor Adams' proposed budget cuts to one of the most vital resources in New York City. Rather than cutting the budget for the safety net system, providing care to millions of New Yorkers each year, we should be working to invest in NYCHHC. As it stands, our hospitals are seriously understaffed at this time. Resident physicians are constantly filling in gaps to ensure patients get safe and quality care. We're often doing tasks that fall out of our roles, including transporting patients, drawing blood, and helping set up appointments for our patients when they leave the hospital. We're all passionate about providing great care to New Yorkers for every minute we spend doing these tasks, but we are not answering patient questions or family questions and doing what we were trained to do when we were doing all these extra tasks. It's exhausting for us, and it's not fair to our patients to provide the excellent care that we could be providing. NYCHC needs more nurses, more phlebotomists, social workers, patient care techs, and many other positions, and this council and every level of our government must invest in this system. One of the urgent needs that I want to discuss today is language access. New Yorkers speak over 200 languages, and we need translation equipment and need to hire in-person translators so that we can ensure we're properly handling the complexities of our patients' cases. Currently at Kings County, we don't have proper access to Haitian Creole interpretation between the hours of 8 p.m. and 8 a.m. It's a large part of our population, and currently we have video interpreters and phone interpreters, but not always does that work for us, and especially after hours, in between 8 p.m. and 8 a.m., care for our patients doesn't stop there. We have to oftentimes wait for 45 minutes to get connected to a Haitian Creole interpreter, and oftentimes if they can't hear or see our patients, some translation is lost. So we want to thank you, Chair Narcisse, for your leadership and support of CIR's efforts to improve language access at Kings County Hospital. And we hope that this budget will fight against cuts to H&H and fight for language justice at Kings County and all of our H&H hospitals. New York should lead the way nationwide in creating a more humane, compassionate, and equitable healthcare system by supporting H&H and its workers now. I'm calling on this body to do just that and to resolutely and loudly oppose this proposed budget cut and for the well-being of millions of New Yorkers who rely on health and hospitals for the union workers who care for them. Thank you.
I thank you for your testimony, and I'm in agreement with you. And one of the things we spoke about and Dr. Katz committed to is making sure that we have the interpreter or translator, Haitian Creole. He has budget and he's gonna look into it. He told me consider it to be done. So that answered that question. And as far as we committed to make sure that New York City, we have the best quality healthcare, we're in, and all my colleagues are on, we're on the same page when it comes to that. So I thank you for your testimony.
Thank you. Dr. Michael Zingman.
Hi, my name is Dr. Michael Zingman. I'm a resident physician in psychiatry at Bellevue Hospital and also the Secretary Treasurer for our union, the Committee of Interns and Residents, which represents more than 7,000 physicians in New York, including over 2,500 in H&H itself. Every day, I see what H&H is capable of at its best in terms of offering quality, accessible care to people who otherwise could not access care. But my fellow residents and I also see, as well as anyone, where there are startling gaps in resources that our elected officials must address immediately. There is no doubt in my mind that supporting the hospital system, H&H, is one of the most important things our city and state can do for the public health of New York. This budget must invest in H&H, not cut funding for H&H. As residents, we experience the impact of the current underfunding of H&H every hour we spend in the hospitals. We are severely understaffed, which means residents are constantly covering gaps, doing blood draws, transporting patients, and so on, instead of focusing on the aspects of patient care we were trained to provide. Our patient care census also continues to be high and is not decreasing. This makes it untenable for healthcare workers and is untenable for our city. Nothing could be more important than properly investing in H&H so that we can better staff these essential safety net hospitals. This also means paying healthcare workers fairly. Elmhurst Hospital resident physicians who are employed by Mount Sinai should not make less than those at Mount Sinai Hospital on the Upper East Side. Likewise, Bellevue residents, such as me, should not be paid $5,000 a year less than our colleagues who do the same exact job as us, but happen to be employed by NYU Langone. Like our nursing colleagues, we need pay parity for all New York City healthcare workers. I also urge all city and state elected officials to use your platforms and your offices to advocate for the inclusion of coverage for all in the state budget. We should be expanding coverage through the Essential Plan for undocumented New Yorkers because it's the right thing to do, but also will save the state money and mean higher reimbursement rates for H&H, where these hospitals currently provide the bulk of care for undocumented New Yorkers through emergency Medicaid. As a union, one of the ways CIR works to improve patient care and the education needs of residents is through the Patient Care Trust Fund, which is part of our contract. The PCTF awards grants for research and equipment annually. Every year we receive millions of dollars in equipment grant requests from residents across the H&H system. To apply for the grant, residents have to sign off from their program and faculty to assert that the department and hospital do not have the means to purchase the equipment. And every year, so many of these equipment grant applications are for basic equipment needs that it would be unthinkable at many hospitals that we wouldn't have them. We need more resources and funding, not less. Yet Mayor Adams is proposing we cut H&H funding while simultaneously suggesting that we increase forced removals or hospitalizations for unhoused New Yorkers, another move that harms public health for the most underserved populations in this city. Everyone listening must at least agree that resident physicians and other healthcare workers should not have to scramble and exhaust ourselves day in and day out to provide quality care and keep patients safe in the largest and what should be the best public healthcare system in the US. We deserve better and our patients deserve world-class care. Thanks.
Thank you, doctor, for your testimony. We are here to support hospital H&H. It's very important to me and to all my colleagues. And I have been a nurse for over 3 decades, so we're supporting the staff in the hospital because we need the best quality health care in New York City. So thank you for your work and thank you for your commitment.
Thank you. Now we'll move back to in-person panels. I will call on Crystal Sims, Shaina Martson, Abulaji Adememe, Marison Parkins. Yes, please come. You can go in whatever order you would like. Please just state your name before. Thank you.
Can you hear me? Okay. Good evening, and thank you to the chair and to the committee for hearing from us today. My name is Shaina Morrison, and I'm a nurse. I'm a member of NYSNA, New York State Nurses Association, representing more than 9,000 nurses in the public nurses sector of H&H and mayoral agency. And I work at Rikers Island Correctional Health. Working as a nurse at Rikers Island Jail is not for the faint of heart. It requires high level of skill, attention to details, and a commitment to providing quality care in a challenging environment. We must be aware of the dangers we face and take steps to protect ourselves and our patients while still providing the care they need. Nurses working at Rikers Island Jail face unique and significant dangers every day. The nature of the environment we work in, the type of patients we care for, the inadequate staffing levels, all contribute to these dangers. These nurses are exposed to physical assaults, verbal assaults, verbal abuse, and these nurses are exposed to physical assaults and verbal abuse and infectious diseases, all of which can have long-term impacts on the physical and emotional well-being. Many of our patients are often dealing with complex medical and mental health issues that require specialized care. Many of them feel forgotten and abandoned in jail. Incarcerated people too deserve the best health care they deserve, and they deserve to be supported compassionately. At Rikers, we must provide total care, including vital signs and wound care. Okay. Sometimes the nurse is working without the support of a patient care attendant or an LPN. So just one nurse will be rounding, documenting medical notes, and managing medication all on their own. The staffing crisis in New York City has created safety concerns within our jail system. We have one nurse at sometimes covering 2 mental health units, totaling 50 patients. That's right, 50 patients. This is beyond short staff and has become a true crisis. But our work feels impossible to do in a 12-hour shift, forcing us to stay beyond our shift to complete our task. This stress is not the fault of our patients. We burn out and naturally take the energy home to our families. H&H is underfunded, and our staff is underpaid. Nurses get sick. Sorry.
It's okay. You can, this is your home.
We get sick. We get pregnant. And yet, our pay and our benefits is not comparable to our private sector colleagues. New York City Health and Hospital Mayorals helped save New York during COVID. We are asking for financial support in order to provide better pay and better working conditions. We don't want to work 2 jobs. Our current job should be effective and should be enough for us to provide for our families, to be able to pay our rent, to be able to send our kids to school. The amount of money I get for a year, they're telling me that my son, I cannot get any federal support because I'm making a lot of money. And they're not thinking about the bills I have to pay. They're not thinking about anything like that. But I work, and I decide to work at Rikers Island because I want to serve a population that is underserved. And a lot of people don't want to work in that area, but I choose to work there because I want to give back to my community and to people who look like me, because I care. So we're calling on the city to live up to its commitment to pay parity between the public and private sector. Thank you for this opportunity, and I'm sorry.
That's okay, don't be sorry, because I hear you. Being a nurse, going to Rikers Island is a tough place to be. And thank you for your service, because not like you said, I don't think many people want to be there. And for you to be there, that's the least we can do. And we are committed to ask questions and push forward and do whatever we can when it comes to budget to make sure that this gap is narrowed down or gone completely.
Thank you. And I sat here and I listened to Ms. Yang talk about correction, and they have the staff. They don't. It's a
They don't have
crisis.
the staff.
They don't have the staff. I'm a living example. Every day the nurses there are working short staff. They're taking on more tasks than they're supposed to. And management tell us we're hiring, we're this, we need the support. We need the support. And I wish he was here to hear it from me personally. We need the support.
Okay.
Thank you.
Thank you.
All right. One other thing too, we're gonna follow up, because whatever I mean, I was hoping they can stay, but most of the time they don't stay. But it's not the end. They're gonna get everything you said right here
Thank you.
and get a letter follow up and ask the questions.
Thank you.
Thank you.
You're welcome.
Thank you.
Good evening. My name is Marian Parkins. I'm an RN. I have been a registered nurse for 29 years. I have worked at Harlem Hospital for over 30 plus years. I want to thank the committee chairs and the council for taking the time to hear from me today. I strongly encourage the city to direct more funding towards NYC H&H. We are in a staffing crisis. And when I say it's a crisis, it's a crisis. This is the worst of the COVID-19 pandemic has ever ended, but heavily patient load continue. Staffing is the worst that I have ever seen in my time as a nurse. We have more agency nurses working in our hospital than staff nurses. We hire new nurses, but they leave quickly to higher salaries and less patients. At city hospitals, not enough staff means worse care for our patient. There are long waits, our emergency department is swamped. Sometimes patients choose to leave before receiving the care they need. On our med-surg floor, nurses do bladder scan, they do all the blood works, and they don't get break, but they have to go and give the tech break that doing the one-to-one. And now they're rolling out new plans for the nurses to do. I spoke with 2 nurses a week ago, leaving the facilities at after 9 o'clock, because they have to stay at the bedside and round and do other stuff before they leave the hospital. You have a 54-bed unit with only 5 nurses, and if an agency is there, she can walk out. The city hospital need more staff, you know. There are during the height of COVID, travel nurses were brought in but not trained to provide proper care. This doubled the workload of our staff nurses. The nurse-to-patient ratio in our contract has never been respected, and we are disrespected. There are times when nurses come to work and they care for even 20 patients at a time. Where's the care? There is no acknowledgement that we are working on the staff. Management is disrespectful when dealing with the staff. To provide safe quality care for New York City, we need enough nurses at the bedside. Even traveling nurses are choosing to work at wealthier hospitals, leaving us nowhere to turn for relief in the city hospitals. We need permanently trained staff, not expensive short-term travel nurses that undermine the quality of our care for our patients. On top of low wages, our pension was dramatically reduced with Tier 6, and our health care is at risk. We need fair funding to New York City in city public health care system. Pay parity and fair working conditions are both vital for recruiting and retaining nurses for the community. Thank you for your time today.
Thank you for your testimony, and we hear you.
First, I want to thank City Council, Nurse Narcisse, Honorable Nurse Narcisse, and the Hospitals Committee for holding this hearing today and listening to the frontline nurses. H&H is a fantastic place to work. I've been there for 16 years. There are many wonderful, caring, empathetic colleagues from all walks of life to engage with. Our patients are interesting, some medical marvels, survivors, and most importantly, demographically diverse, mostly Black, Caribbean, Latinx, English, and non-English speaking immigrants from all across the world. Many of our patients are in the NYPD, FDNY, incarcerated, commercially insured, uninsured, or underinsured. And they all deserve the same quality health care as anyone else in this country and in the beautiful city of New York. but the crisis of understaffing and high turnover at our public hospitals threatens care for New York City's most vulnerable patients. Over the past 3 years, we have had a tremendous exodus of nurses leaving our public hospitals. H&H has not provided a comprehensive system-wide data on turnover, vacancies, or the amount of money that's going toward filling staffing gaps with temporary agency nurses. An internal report at Jacobi showed just how bad the understaffing and turnover is at my hospital. Between February and November of 2022, about 183 nurses total left Jacobi for any reason, including retirement. Of those, 115 resigned for reasons other than retirement. In total, approximately 20% of all staff nurses at Jacobi left during those months. 25% of the nurses who resigned didn't even make it a full year. The most resignations were from the emergency department, 24, where our colleagues tell us that a nurse quits almost every shift because working conditions are so bad. Almost every unit in the hospital has had at least one vacancy, as of January 2023, with as many as 8 vacancies in some units. Because H&H is limiting the financial backing to support and keep dedicated and experienced nurses at the bedside long term, there has been a reliance on expensive agency nurses that make 2 to 3 times the salary of staff nurses, thus decreasing staff morale. To note, it is not $70 an hour that nurses make in H&H, it's $43.45. $43.45. As of January 2023, 53% of active nurses in critical care areas at Jacobi were agency nurses, and 59% of active nurses in med-surg areas at Jacobi were agency nurses. There were 146 agency nurses at Jacobi on average over a 3-month period from November 2022 through January 2023. Even with a very conservative estimate, the city is likely spending $18.5 to $24.2 million per year on traveler agency nurses just for Jacobi alone. Nurses have left because of burnout from COVID-19, because they're tired of working short-staffed, and because the pay is so low. Many of us are frustrated by not being able to provide the care our patients deserve due to the demands of an unjust healthcare system. The most detrimental plight is that nurses in H&H cannot continue to be financially marginalized from being paid a fair wage as our public sector sisters and brothers to the tune of $19,846 difference. As a nurse practitioner, when I get called by the sickle cell patient that's been in the emergency room waiting for pain medications for over 45 minutes, I cringe. The patient does not know or understand that they are not forgotten or unprioritized. It's just that there are not enough nurses to care for our bustling emergency rooms with 1 nurse to 20 or 30 patients. Or worse than that, imagine being a patient in the ER and hearing level 1 trauma over the loudspeaker. That could be a heart attack, stroke, horrific car accident, a gunshot wound, or stab victim, and simultaneously happening. H&H trauma facilities pride ourselves on taking care of the critically ill, yet our monetary value and worth are not equal to the care we provide. What about the cancer patient who is nervous, distrustful of the healthcare system, not healthcare literate, and cannot afford their chemotherapy? Those are the patients that I take care of every day. It gives me great pride to be able to be the trusted provider to educate and guide these patients that look like me and are reminiscent of my own family, providing them with compassion, patience, and dignity. When that same patient's eyes glisten when they see me during that clinic day and they update me on the good, the bad, and the ugly of their treatment or their personal life because they trust the care we give. It pains me to think that I have to choose between these meaningful relationships and the value of my work, choosing between my purposeful career and how to balance my checkbook, or taking on per diem jobs and overtime to make ends meet. With most of our nurses being the same demographics as the patients that we see, why shouldn't we have the health equity for our patients and ourselves? I implore the City Council to help the H&H mayorals stop the bleed of nurses from H&H to the private sector. We train nurses and help to mold the residents that become physicians with teamwork and collaboration. We cannot afford to train our nurses for 3 to 12 months and then they leave with a wealth of knowledge for a higher paying job. This decreased return on investment is disgraceful and an outrage, as the aging nurses are entitled to retire at some point. Ms. Parkins. However, who will continue to care for our patients if we cannot retain these nurses in the current state of affairs? The number one reason that nurses give in exit interviews for why they're leaving Jacobi is a low salary that doesn't compete with the private sector. We're calling on the city to follow through on its agreement for pay parity with the private sector. The city made that commitment in our contract, and it's time for them to follow through. Our patients need nurses to stay on for the long run, and that won't happen without pay parity. Thank you.
Thank you for your testimony. Appreciate it. We heard you loud and clear, and we have your testimony.
Thank you.
Thank you.
Before you go, can I have your name?
Oh, I'm sorry, Crystal, Kristle, Sims, Simms.
Thank you.
Thank you.
We will move, the next panel will be Moon Yuk Yu, Justin Wood, Chris Norwood, and Thomas G. Apologies if I mispronounce someone's name. Please begin when ready.
Good afternoon, Chair Narcisse. My name is Moon Yuk Yu. I'm the Director of Policy for the Office of Brooklyn Borough President, Antonio Reynoso, and I will be representing him in his testimony today. Thank you again for holding this hearing today. I am here to speak about the staffing crisis within our public hospitals. We can only achieve health equity when we properly staff our hospitals and have pay parity. Funding for our public hospitals this budget cycle must consider the following: safe staffing ratios. Nurses are the backbone of the healthcare system. It has been nearly 2 years since New York's nurse staffing law passed, but our hospitals are still operating at unsafe staffing ratios. As of February 2023, the medical intensive care unit at H&H Kings County Hospital, for example, is operating at a 4.873 to 1 patient to nurse ratio, far above the 2-to-1 ratio required by the state legislature. High nurse to patient ratios are related to a 7% increase in hospital mortality for each additional patient as a result of infections like pneumonia, cardiac arrest, and 60-day mortality and readmission. Treatment costs for these issues could be mitigated when appropriate staffing ratios are put into place. Safe staffing also reduces stress, anxiety, burnout, and turnover among staff. This has a potential of saving costs for recruitment and training, which together cost $82,000 to $88,000 per new hire. The crisis that we face is not just a shortage of nurses, but in safe work environments, and it puts healthcare in peril. The second issue I want to discuss is pay parity. Not only are unsafe staffing ratios a risk for staff attrition, pay gaps between nurses in the public and private sectors are forcing nurses to leave our public hospitals, as we've heard today. At the heels of private sector nurses winning historic agreements that enhance safe staffing ratios and raise their pay by 19.9% this past January, we owe our public sector nurses the same, and we will witness a growing pay gap of $19,000 between public and private sectors. Right now, we're not paying our public sector nurses what they need and deserve, so instead they're leaving for private institutions that pay more and provide better contracts. And this creates a detrimental cycle of staff shortages that in turn affect staffing ratios. The third issue I want to discuss is midwifery care. Currently, New York City faces one of the most severe maternal mortality crises, with Brooklyn having the highest rates. During my first year, I invested my entire capital budget of $45 million to 3 Brooklyn H&H hospitals so that they could improve their NICU and mother-baby units and build state-of-the-art birthing centers. I hope that these capital investments will allow our hospitals to in turn invest in its personnel. Of these personnel improvements, I want to call attention to our midwifery workforce. A facility with adequate staffing of midwives can avert 41% of maternal deaths, while even a moderate increase in staffing can avert deaths by 22%. When I started my fatherhood journey, I was disappointed to learn that 3 of our Brooklyn H&H hospitals, of our 3 Brooklyn H&H hospitals, Woodhull is the only H&H hospital, Brooklyn H&H hospital, that has centered midwives in obstetric care for our birthing people. In 2019, 68.1% of its births were attended by a licensed midwife, while the number was disproportionately lower at Kings County Hospital and Coney Island, South Brooklyn, at 15.8% and 17.3% respectively. I was further surprised to learn that at Kings and South Brooklyn, midwives are not always playing a leadership role, and some birthing suites house only 1 midwife. Midwives need to be part of a patient's care journey from day one. I highly encourage the administration to consider investing in expanding midwifery care and ensuring that midwives are holding leadership positions so that we can put a stop to this preventable maternal mortality crisis once and for all. Thank you again for this opportunity to testify today. I look forward to working with the council through the budget process to ensure that our public hospitals have the support they need to provide equitable and quality care.
Thank you for your testimony. I'm sorry for the sound you hear. We have an event next door that was scheduled.
I was afraid
So-
I was on my phone doing something.
You know,
That's okay.
this is the
Thank
people's
you.
house, so different things going on.
All right. Thank you so much. I'm Chris Norwood, Executive Director of Health People. I really wanted to look at some overall issues of policy and funding. The first is the need to truly incorporate community groups into the work and mission of H&H and other hospitals. In this endless crisis of staff and overwhelmed facilities, the value of community groups is that many have proven programs that reduce emergency visits and hospitalizations. A lot of these programs for asthma, as you heard, mental health, high blood pressure, diabetes, proved themselves during the last 115 waiver. Health People, my own organization, for example, under H&H at that time, took the 6-session diabetes self-management program right into homeless shelters. Evaluation by DOH showed that emergency visits for the 201 participants plunged by 45% and hospitalizations by 74% in 6 months. I would hardly feel in a position to second-guess the administration of H&H and all they did during the pandemic. But I think it is really time to start thinking of things another way and how aligning with community groups and finding out ways to support them can totally contribute to the mission of H&H by keeping their patients as well as can be and out of the hospital. I would also suggest that if we analyze the asthma program, that actually it can be delivered for less cost in the community. The other policy and funding issue is to look at things that are incredibly expensive that should not be occurring. I know we've discussed as a major example of that diabetes-related lower limb amputations, which have grown by 100% in New York City in 10 years, and which cost, it's not only that they cost so much financially, they're now about $500,000 in direct medical costs over time, surgery, anesthesia, prosthetics, a lot of mental health counseling for people who are totally shattered. It's what they cost hospital systems. The use of personnel, the pressure. People who that happens to are always in the emergency room later. So I use, in 2 minutes, as much as I can to suggest it's all hands on deck and to suggest how we can all work together to use the resources that are available to support wellness that benefits the hospital system and benefits the people in the community. Thank you.
Thank you for your testimony. I believe in preventive care, so that's all right. Thank you. I appreciate you.
Thank you.
Thank you so much, Chair Narcisse, and to the other members of the council for holding this hearing and for the opportunity to testify. My name is Justin Wood. I'm the Director of Policy at New York Lawyers for the Public Interest. I'll try to skip around a little bit here and we'll submit a full written statement. At the outset, we want to thank you and the entire City Council for continuing to support the Immigrant Health Initiative for the last few years. That has directly supported our work in immigrant health and improving the health and well-being of all sorts of immigrant New Yorkers and families through health education, outreach, and sustained policy advocacy. So we want to open with a big thank you for that. Also appreciate the questions and Health and Hospitals going on the record today in strong support of coverage for all. This would particularly impact, you know, up to 245,000, excuse me, immigrant New Yorkers who are uninsured currently. This would have a huge impact for New York City communities of allowing uninsured New Yorkers to enroll in the Essential Plan. This is a very active issue in the state budget discussions now. And of course, it's very relevant to this committee and New York City's health and hospitals, partly because this would just improve health outcomes, financial stability, reduce ER visits, and save lives for uninsured New Yorkers to be able to enroll in a comprehensive health plan. And then secondly, this is a win-win for our city and our state's economy. It allows, you know, better outcomes, allow people to be more productive. The comptroller has found $700 million in savings to New York City from Coverage for All. And of course, for H&H, we're currently budgeting $100 million, we heard today, for NYC Cares. And the hospitals are receiving inadequate compensation from Emergency Medicaid, which is a very inadequate program. So we thank you and the council for passing resolution, I believe it was 84 last year, in support of Coverage for All. And of course, we urge every elected official to use their voice with the governor over the next 2 weeks or so to get this into the budget and support the Senate's version of this. Just finally, I know we're over time, wanted to highlight some work that we hope to do with you and other members of the committee on transplant equity. One of the big issues our clients come to us with in New York City is inequitable access to kidney transplants in particular. We know that when people are uninsured or relying on emergency Medicaid, they often don't even get access to screenings at transplant centers. And we know that kidney transplants, when compared with long-term dialysis, improve outcomes, save lots of money for the health system, and again, save lives. So we have a pilot program at SUNY Downstate, actually, a transplant equity pilot program, where we've started to do this work. It includes provider education on insurance options for patients. It includes coordination and specifically hiring immigrant health coordinators, language access to make sure that that transplant care is available to all. And we would love to see this program scaled up at other safety net hospitals like H&H and work with the council to secure that funding. And we are in touch with H&H about that as well. So thank you very much for the opportunity to testify this evening and for the work of this committee.
Thank you for your testimony. Like I told you, I'm very much interested in that. Thank you.
Thank you all. Now we'll move on to the remote testimony. If you're on Zoom, wait for me to call the panels and then wait for the sergeant to cue you. The next panel will be Carmen Garcia, Mada Ghosh, Amari Tavira, and Zachary Katz-Nilsson. Jennifer J. Parrish, Sue Allen Dotel. We will begin with Cameron Garcia. Whenever you're ready.
Starting time.
Good afternoon, and thank you, Chairwoman Narcisse. My name is Carmen Garcia, and I'm a community health worker supervisor at Make the Road, New York. With a membership of 25,000, Make the Road has now been serving New York immigrants and working class communities of color for 25 years. We provide health, legal, adult education, and youth services, plus community organizing, transformative education, and policy innovation. Make the Road's fiscal year 24 budget requests on behalf of immigrants and working class New Yorkers include the following. We request $200,000 for Make the Road under the Speaker's Initiative for a wraparound health, legal, adult, literacy, and youth services reaching over 15,000 individuals per year citywide. City Council must expand funding for the Access Health Initiative to $4 million, allocate $2.3 million in funding for the Managed Care Consumer Assistance Program, and maintain funding for ending the epidemic at $7.7 million and the Immigrant Health Initiative at $2 million. We request renew allocations to Make the Road of $110,000 under the Access Health Initiative 80,000 under the Immigrant Health Initiative, 76,218 218 under the MCCAP initiative, and 75,000 under Ending the Epidemic to help address healthcare disparities. 50,000 from the Food Pantries Initiative for our pantries in Queens and in Brooklyn. We request also continue funding the Community Health Worker Asthma and COPD program, in which NYC Health and Hospital partners with community-based organizations like us. We directly hire community health workers who then work at H&H sites and are part of the care team, supporting H&H patients with home visits that address environmental factors and other services that address social determinants of health. And this is essential that so this program continue to partner and fund CVOs. We ask that the council and the mayor continue to advocate for coverage for all in the state budget, and for the state to include immigrants in the 1332 waiver request. This would allow the state to access federal funding to expand health coverage to all immigrants regardless of their immigration status. The administration must expand funding for the NYC Care program to guarantee low-cost and no-cost services to New Yorkers who don't qualify for or can afford health insurance. NYC Care must receive $100 million per year to continue the program with CBO partners. They should also receive added funds to expand the program to federally qualified health centers. Thank you so much for hearing. Thanks.
Thank you for your testimony. Thanks.
Thank you, Carmen. Next is Medha Ghosh, whenever you're ready.
Starting time.
Good evening. My name is Medha Ghosh, and I am the Senior Policy Coordinator for Health at CACF, the Coalition for Asian American Children and Families. Thank you very much, Chair Narcisse, for holding this hearing and providing the opportunity to testify. Founded in 1986, CACF is the nation's only Pan-Asian children and families advocacy organization and leads the fight for improved and equitable policies, systems, funding, and services to support those in need. Nearly 19 million people reside in the New York City metropolitan area, and over 800 different languages are spoken. Because of New York's linguistic diversity, it is incredibly important to ensure language access. Language barriers are a huge obstacle faced by many folks in immigrant communities, and especially in the AAPI community. In New York City, the AAPI community has the highest rate of linguistic isolation of any group, as 46% have limited English proficiency, meaning that they speak English less than very well. Moreover, more than 2 in 3 Asian seniors in NYC are LEP, and nearly half of all immigrants in NYC are LEP. Language barriers can prevent folks from accessing vital services like healthcare. Despite there being 76 language access policies targeting healthcare settings in New York, we have found that many LEP patients still report facing difficulties like being unable to find an interpreter that speak their dialect, or being unable to fill out paperwork because a translated version in their language does not exist. A lack of linguistically accessible services in hospitals can have grave consequences. More than half of adverse events that occurred to LEP patients in U.S. hospitals were likely the result of communication errors, and nearly half of these events involved some form of physical harm. Our campaign, Lost in Translation, aims to ensure that New Yorkers have equitable access to linguistically and culturally responsive healthcare services. As part of our work, we conducted a focus group with patient navigators to better understand the experiences of LEP patients. One navigator stated, "A child was asked by a doctor to interpret for his mother. The doctor told the child that his mother had cancer, and the child refused to tell her. The doctor continued to ask him to interpret even though it was not his responsibility. Putting the burden of interpretation of medical information on the child of a patient is beyond unacceptable. New York City's H&H hospitals and clinics must have readily available quality interpretation services at all times. In addition, our city's hospitals must provide quality translated materials to ensure that our LEP community members have access to accurate, up-to-date information. For fiscal year 2024, we urge the New York City Council to oppose the proposed budget cuts and ensure that the budget for H&H hospital and clinics include better access to quality interpretation and translation services for our LEP patients. We also want to uplift coverage for all and hope the council will use their voice to ensure that it is included in the state budget. Thank you very much for your time."
Thank you for your testimony.
Thank you. Next is Amarliz Tavira. Ready? Begin when you're ready.
Starting time.
Thank you, Chair Narcisse, for holding this budget hearing and allowing me to testify. My name is Ashley Conrad. I am the Senior Community Organizer at Freedom Agenda. Unfortunately, Amarliz Tavira can't be here, so I will be reading testimony on her behalf, which I will begin now. My brother Eric Tavira was 28 when he lost his life inside of Rikers Island. My brother took himself to a metropolitan hospital to seek treatment. Instead, Dad got him a trip to Rikers Island instead. My brother was waiting to be looked at. There is a video that was released by a news reporter about that incident. It showed how my brother was waiting, and then all of a sudden, he starts a conversation, or what appears to be a conversation or argument, with someone behind the camera. It turns out that that person was a hospital police. Unfortunately, the hospital police did not de-escalate the situation, but what the video clearly showed provoked my brother. My brother was diagnosed with schizophrenia at the age of 16. That is something on the record, especially in a hospital he had been in before. He struggled with it most of his life, until the end. The video was very disturbing. It showed clearly how my brother begged for them to stop what was happening. All he wanted was help, and they had denied him that. The hospital and the hospital police. Maybe if the city were to fund the hospitals more than they do Rikers, it may have made a difference. The Department of Corrections has more officers than people in their custody, but still, my brother died there due to lack of care. What if the hospital had more medical staff there that day than patients, or than NYPD? There would not have to be as much hospital police who are still police and not professionals in treating people with mental illness. We need more doctors and nurses for hospitals to be able to treat any and every patient that comes in and not criminalize them. Instead, the mayor is trying to add more money to the DOC's budget, but I ask that you not let that happen. All the extra money being wasted on extra staff at Rikers who don't even care for the people in their custody should be moved to hospitals and treatments for people in the community so we can get people the help they need and finally close Rikers. My brother was a beautiful human being who had a severe mental illness and just needed help. Thank you.
Thank you for your testimony.
Thank you. Zachary Katz-Nelson.
Starting time.
Thank you. Good evening. I'm Zachary Katz-Nelson, Executive Director of the Littman Commission. I'd like to speak out about Rikers and the secure hospital beds that Chair Narcisse and Councilmember Ressler raised earlier. Thank you for doing so. I just want to reiterate how crucial the 400 secure hospital beds are to our effort to close Rikers and ensure people get the care that they need. As soon as those promised beds are brought online, those folks can be moved out of the chaos of Rikers and into proper care. So please do continue pushing H&H and the Department of Correction at every opportunity to ensure those beds come online as soon as humanly possible. But please do not stop there. Those beds are meant primarily for people with physical illnesses rather than mental illness. And so very few will be able to help people with serious mental illness. There are over 1,100 people at Rikers with a serious mental illness right now. Mayor Adams himself has said repeatedly that people with mental illness should be in treatment and not jail, but we need to make sure the beds are there to provide them with the treatment that they need. Similarly, about half the people coming into Rikers battle with drug and alcohol addiction, and they too need care. Imagine if we could provide them with treatment in secure beds outside of the jails. If we built not 400 more beds, but 1,500 therapeutic beds in the hospital system, we'd be providing people with the care they need, and every one of those would be filled. That's how great the need is amongst people at Rikers. If we put that money in the budget, together we can move people out of the chaos and violence of Rikers into care, and we can do it as soon as in the next couple of years. So we'd love to work together to try and make that happen. Thank you so much.
Thank you for your testimony. Appreciate it.
Thank you. Jennifer Parrish.
Starting time.
Good evening. Thanks for this opportunity to testify. My name is Jennifer Parrish, and I'm the Director of Criminal Justice Advocacy at the Urban Justice Center Mental Health Project. And I'm testifying today to stress the need to close Rikers Island and reduce the number of people with mental health challenges who are incarcerated in New York City jails as soon as possible. The council should fund an expansion of outposted therapeutic housing units to move people with mental health challenges and other health conditions out of city jails and into specialized units in city hospitals. This can be done in advance of the closure of Rikers Island. Correctional Health Services recognize the need for people with health conditions who require a higher level of care to be placed in housing units outside of Rikers. The city committed to open outposted therapeutic housing units in Bellevue, Woodhull, and North Central Bronx hospitals. These units are expected to include approximately 390 beds. Unfortunately, the opening of the Bellevue unit, which was originally planned to be completed in December 2022, has been delayed. The council should urge the completion of these therapeutic units be expedited and that the model be expanded. 390 beds are simply not enough. The number of people diagnosed with serious mental illness in the jails has been increasing over the last 3 years and is now about 20% of the jail population. That is more than 1,100 people in need of significant mental health treatment, languishing in DOC custody, subjected to some of the worst jail conditions in the country. In the jails, there are mental health units that purportedly provide a higher level of care. However, the mental observation units do not have mental health staff stationed on the unit, and even the quality of care on the PACE units has declined in the last few years as Department of Corrections dysfunction has resulted in unstaffed posts and prevented people from receiving the treatment they require. In fact, 2 of the 19 deaths that occurred last year took place on mental health units. It's imperative that we get people who are assessed as needing to be in specialized mental health units off of Rikers and into outposted therapeutic housing units. Although people in these units will still be in DOC custody, they will be safer and more likely to have their treatment needs met in these units than Rikers. We urge the council to support expanding funding for this purpose. Thank you.
Thank you for your testimony. We hear you clearly. Thank you.
Thank you. Lastly, Sue Ellen Dodell, whenever you're ready.
Starting time.
Good afternoon. My name is Sue Ellen Dodell. I'm a lawyer and I've worked for the city since 1979. I'm concerned about the effect on public hospitals and the effect on the H&H budget of the contract that the city is about to enter into with Aetna for a Medicare Advantage plan for city retirees. The plan is inferior to traditional Medicare because it reduces retirees' access to necessary medical care and will have grave consequences for the H&H budget. City retirees will be forced to delay necessary care, resulting in an increased reliance on urgent care facilities, emergency rooms, and Medicaid. As you conduct today's budget hearing and think about the effect of the Aetna plan on public hospitals, consider that private hospitals do not have to remain in the Aetna plan, and their withdrawal from the plan will virtually ensure that public hospitals in New York City will be forced to serve these patients. This increased demand on city hospitals will greatly impact the city's budget. Further, because the care received by city retirees in the Aetna plan will be inferior to traditional Medicare, it will result in increased costs to the city when retirees and others covered in the Aetna plan will need to seek treatment at H&H hospitals. I urge you to support the legislation sponsored by Councilmember Farias, which would continue to provide retirees with a robust Medigap plan. Thank you.
Thank you. Heard you loud and clear. Thank you so much for your testimony.
Thank you. Thank you. If there's anyone present in the room or on the Zoom that hasn't had the opportunity to testify, please raise your hand. Seeing no one else, I would like to note that written testimony, which will be reviewed in full by committee staff, may be submitted to the record up to 72 hours after the close of this hearing by emailing to testimony@council.nyc.gov. I will now recognize individuals who signed up to testify but did not show up. Dr. Anju Rao, David Miranda, Kimberly George, Thomas G., Sharon McLennan, Elise Benusa, Joan Calcuta, Alex Stein. Thank you. Chair Narcisse, we have concluded public testimony for this hearing.
I want to say thank you to everyone, and thank you for everyone that testified, and all the staff here. Thank you so much. It was a great hearing. I appreciate your time. So, seeing none, we close the hearing.
We survived it. That was the intention from the beginning.